Which screen is Zoom? They have her do it. She's having to do it with all different things. Trust you. Is fabulous. Oh my gosh. She's got a couple of birds. Oh, they all ended up in speakers.
Morning, everyone. I'm Ann Garst-Taylor, and I am with AIM at Melanoma. We are now going to wait about 1 minute for the folks that are joining us via Zoom and Facebook and YouTube to join in. And then we'll get started. So if you just give them about 30 seconds to a minute, and then I'll give you some instructions on questions and answers. Thank you so much for joining us today. It's just amazing to have a room filled with people again. Isn't this wonderful? Wonderful feeling, isn't it? I hope we are back to normal again, or whatever that's going to be, right? A few more seconds. Make sure that everyone's on here for this one. Okay, I'll go ahead and get started again. I'll repeat what I said before because we want to make sure everyone who has joined us virtually has an opportunity to hear. Welcome. I am Ann Garst-Taylor. I am the Director of Community Engagement for AIM at Melanoma. I have recently been given the responsibility of running our seminars from our president, Sam Guild. It is my great delight to be here. She sends her hellos to everyone. If you don't know Sam and her family, 19 years ago, AIM at Melanoma was founded by Sam's mother, Val Guild, when she lost her precious daughter to melanoma at the age of 26. And since that time, the mission of AIM at Melanoma has been to end the disease in our lifetime, and in the meantime, to support those individuals who are living with melanoma. And I'm going to have an opportunity at the end of our time together to tell you a little bit about what those supports look like. But I have two very quick jobs up here this morning. The first is to thank Dr. Sondak and the Moffitt Cancer Center for co-hosting today's symposium with us, and of course to thank all of our esteemed panelists for the presentations that I know that we're all looking forward to. I also want to thank Megan Potts, wherever she is, for her superior organizational skills. She has been essential in the success of today's symposium. And also we have two wonderful volunteers in the back, Sabrina and Kaylin, and they are going to be essential to our question and answer period. So that's the second thing, a little bit of housekeeping that I need to cover. How will you be able to ask questions? Because we know that you're going to have questions for our panelists. So if you're in the room with us today, we have given you a patient packet, and inside of it is a pad and a pen. You will write your questions down, and now we're going to hold up our pink buckets. Can you see our pink buckets back there? If you'll just, when you have a question, if you'll hold your question up, they'll run over with your pink buckets, and we'll let you put your question in there, and then they'll get them up to Dr. Sondak so that he can answer them. If you are joining us via Zoom, then there is a chat feature and a Q&A feature. You are welcome to write in the chat feature, tell us about yourself, and also share where you're joining us from. If you have a question for our panelists, though, please put that in the Q&A session. We have people joining us via Zoom from all across the United States. So hello to everyone. Hello to Sam Guild, who is never far away. She cannot stay far away from these symposiums, and she is joining us as well. And then if you are joining us from Facebook or YouTube, you will ask your question in the comment section. We'll get those written down, and then we'll get those to Dr. Sondak. So without further ado, I'll hand it over for the starting of the symposium.
Great. Well, thank you all for coming. A big thank you for Eamon Melanoma. We've done this kind of live symposium before, but it's been way, way too long. And thank you to all our panelists. We have a very multidisciplinary panel that reflects the way we do things here at Moffitt. We like to think we're here at the end of the rainbow in our McKinley building here, but I hope you noticed that right across the street, we're putting the finishing touches on our new Moffitt McKinley Hospital. When it opens initially on July 31st, it will be our surgical hospital for our inpatient surgeries. And you see the bridge, you can see the bridge is almost complete, and that connects us right to this building. The second floor of this building, right upstairs, is where even some of you may have had surgery here. And it will now connect directly to the hospital via a walkway instead of being a mile away the way we are right now. So we're really excited about the future here, and it's just part of the growth and expansion that Moffitt is going through. Unfortunately, we need that expansion because melanoma is growing, as far as population is growing. That's part of it, but the number of cases in the United States are certainly going up. And overall, including melanoma in situ, nearly 200,000 cases and almost 8,000 deaths predicted for this year. And what you see is that the trend is going up. This is a prediction that was done a few years ago already. And we maybe are fortunately just below the worst case scenario, but they predicted and said, if nothing changes based on the way things were going in 2016, where would we be in 2040? And by nothing changes, I mean, if we can't stop indoor tanning and get a change in our attitudes towards sun and skin protection, where will we be in 2040, less than 20 years away? We would be at more than a doubling of the number of cases, and melanoma would become the second most common cancer type in the United States after breast cancer, and the most common type in men by 2040, if nothing changes about the way cancer cases are going. Now, of course, when we say the second most common major cancer type, they don't even count basal and squamous cancers in their predictions, and we have almost as many basal and squamous cell cancers each year as all other cancers in the United States combined. So that's just a little introduction to the magnitude of the problem and why we're expanding and why we're busier than ever, and why a symposium like this is more important than ever, because not just the numbers are changing, but the treatments are changing as well. And I always say, maybe some of you have even heard me say it, the first thing is we don't take anybody's word for anything. We want our pathologist to look at the biopsy that you've already had to start the treatment, because if we don't get the initial diagnosis right, there's no way we can get the treatment right. So our first presentation, appropriately, is from Dr. Jane Messina, our lead dermatopathologist, and she's going to help you understand your pathology report and how we use it for treatment. Okay?
Thanks. So for the Zoom or Facebook, does it matter where I stand? I stay in the middle? Yep. Okay. I'll probably be looking back at the screen. Thank you so much for the opportunity to talk. I always appreciate the chance to show how important pathology is
And I appreciate the central role that we're given in the care team here. So I hope I try to show what pathologists do in a way that's digestible for people who have no pathology or medical training. So I hope I'm at least partially successful. I also like to know who I'm talking to, and if you're comfortable answering, I would love to know how many people in the audience have had melanoma personally. Wow. And how many of you had a loved one with melanoma? And the above. One, none of the above.
Yeah.
Well, thank you all so much for being here on your Saturday. A lot of times I start this talk out with reference to a show, and usually the last time I gave it, it was CSI, dissecting the clues to figure out what you have in pathology. But this particular talk is more appropriate. Is it Knives Out or not? Because I'm going to talk about the role we play in determining further treatment usually by surgery in early melanoma. And one of the things that's very confusing, even on a medical level, is the number of new tests, all of which seem to have a new fancy acronym. And I'm gonna hope to kind of demystify some of these tests that you may have heard about, some of which are listed there. I'll go through all of these. And so briefly, the objectives that we're gonna do in the next few minutes is to talk about the impact of melanoma on society, the numbers, what happens when your physician suspects you have melanoma, how is your melanoma specimen analyzed, and what are some newer things that we're doing to help understand the diagnosis and the disease. Just kind of the impact, a lot of the numbers that we give are US, and a lot of the statistics we have are for non-Hispanic, white people, so, rather than global numbers. So this is the number of white Americans, 1 in 28 non-Hispanic white Americans that will develop melanoma in their lifetime if they're male, and a few less if they're female. But really that pales in comparison to how many will develop skin cancer in their lifetime. As Dr. Sondak alluded to, it's considered to be altogether equal to all the number of other cancers combined. And to think about melanoma, you have to put it in the context of the whole epidemic of skin cancer in the US, the majority of which is the non-melanoma skin cancers or the keratinocyte cancers, if you like to give them a positive terminology, the squamous and basal cell carcinoma, and I think I left out the numbers here. Oh, no, there they are. Hard to get an idea of the incidence because they're not reportable, but it's estimated over 3 million basal cell cancers and about 1.5 million squamous cell cancers compared to the 186,000 melanomas.
Joe Biden just had a basal cell.
Pardon?
Joe Biden just had a basal cell cancer.
And Jill, right?
Joe.
And Joe.
Joe just had one
Joe
taken
just
off
had
his
one.
chest today.
So yeah, they're the perfect phenotype. So that was the number of new cases, and in terms of the number of deaths, that's also very hard to estimate. We would all love to know how many people actually get non-melanoma skin cancer and die of it. I feel like we see an inordinate number of those cases here because it has a reputation of being less aggressive, but really takes an incredible toll every year. But melanoma, still accounts for about 2/3 of the deaths from skin cancer. And, not just talking about the numbers, but also the cash. It is a humongous part of our national healthcare budget to take care of skin cancer. So does anybody want to just think in your mind, how many people in the US do you think might get treatment for skin cancer a year? And these are about 5-year-old data. That's a humongous number. And the estimated cost, $9 billion. Which is 10% of, 10% of all of our total cancer expenditure. That's a huge amount of money. Luckily, or positively, to decrease this impact, earlier you get it, the longer you live and the easier it is to treat. So if you have, if your melanoma is not spread at the time of diagnosis, you have up to a 99% chance of still being alive in 5 years. This drops to about 60, and actually, those are older figures. I think we'll hear better and more accurate figures about how long you live now if you're diagnosed with stage 4 disease. The good news is most still, about over 80% of melanomas are diagnosed when they're still localized. I'm sure everybody's seen a version of this. We don't have to belabor the ways to pick up the most classic melanomas by the ABCDEs, but we still realize that melanomas, there's a subset of melanomas that are completely inapparent. Both of these images taken offline look, one on the left looks like an intradermal nevus, the one on the right looks like some type of a rash. These are both melanomas. So it's still some cases are slipping through, being diagnosed at later stages, and we're looking for ways to identify them earlier and earlier by non-visual techniques, because we recognize that depending on your level of training, even the best, most experienced practitioner, the dermatologist, has up to, at best, an 80% chance of recognizing a lesion as melanoma. That means like 1 in 5 lesions that are melanoma, they may not recognize as melanoma. So it's a lot of, we have a very low burden of evidence to perform a skin biopsy on things that even remotely resemble melanoma. And that's a huge amount of skin biopsies, it's a huge amount of that healthcare expenditure. And a lot of these biopsies are going to be negative. It's estimated that up to 90% of biopsies that are done with a rule-out melanoma or rule-out atypical lesion have non-melanoma diagnoses. So one of the newer tests that's come along is the pigmented lesion assay by DermTech, and that's a non-invasive way by using a little circle of sticky tape to sample the surface of a lesion, which peels off some genetic material from the lesion, and it's sent to the lab, and it's analyzed for the presence of genetic material for RNA, some 3 types of nucleic acid. If one or more of these markers are present, the test is called positive, and it's supposed to indicate the presence of a higher risk lesion, either a melanoma or a lesion that called severely dysplastic nevus that is typically excised and needs to be excised. And this is what a typical report looks like. This is off their website. If one marker is positive, then it gets a yellow caution. If 2 markers are positive, it gets high risk, and yellow and red lesions will be biopsied. And if one or more markers are 91 to 97% of unequivocal melanomas are positive for the pigmented lesion assay. So yeah, if you recognize it as melanoma and test it, you're good. There's some issues with, a lot of issues actually with false positives. So 42% of benign lesions are also positive for it. And also about 15% of the time when you do the test, it comes back, we didn't get enough material, and it either has to be repeated or you just go ahead and do the biopsy. And the cost of the test is about twice the amount of the biopsy. So this has been increasingly done, but it's we don't have a large healthcare system strategy for how to integrate it in yet because of the cost and because of these issues with a lot of false positive tests and the tests being inadequate. So if you go to get a biopsy, I see that almost everyone in this room has experienced one or more versions of the way to sample a pigmented lesion. The shave biopsy is by far the most commonly done because it's quick. It can be done in the office immediately. The books will say an excisional biopsy, young man, when you're taking your boards, they'll say excisional biopsy is the best way to diagnose a pigmented lesion, but that's not practical in the course of a busy clinic. So the lesion will be removed in the office, put in the jar, sent to Dr. Sondak, and they'll start waiting for my answer. And I have some slides to show you what actually happens to the biopsy after it goes to pathology. It's a multi-step process. For all of the techniques we have now, it's still extremely manual and many people touch the specimen. So the first day it's touched by a pathology assistant who places it in a plastic container. The container goes into a thing that looks like a little, like a dorm refrigerator size processor that costs about as much as a minivan, sits there for 8 hours. And then it's removed, it's taken out by a histotechnologist who cuts very 3 micrometer size slices of the specimen. It's put on the stainer, it's put on a slide, and then finally it comes to us. And so when we get a lesion that's suspected of melanoma, we need, first of all, we need stuff from the doctors on the report. We need to know how, these are all things that help us do our job better. Has the lesion changed recently? How big is it? What did it look like? Was there a previous biopsy? That's really important. These can all influence the way a lesion looks. Obviously, name, age, sex, and location are required. And then our contract is, well, we got to get the diagnosis correct. If it's a melanoma, we need to give them information to guide the treatment and prognostic information if possible. But correct diagnosis, here's how we're going to do it. And then we produce a pathology report. It is important to note on the signature line of your pathology report whether your doctor is board certified as a dermatopathologist, but that's by and large in the US in metropolitan areas, that's 100% of skin biopsies are looked at by a board certified dermatopathologist. Notice that this is a report of a melanoma. There's a lot of things going on here besides just the M word. So I'm going to show you what are some of the things that we do to decide if a lesion is melanoma and how do we assess it. So the first things we do is under the microscope is assess ABCDEs of our own. They're very similar to what you've seen for deciding if a lesion is clinically melanoma. So we can see asymmetry under the microscope. If you divide a lesion in half, one side is often bigger, more cellular, or different looking than the other. We can see the irregularities of the border. All these little vacuolated cells here are melanoma cells, and it's really hard, this purple line is skin. It's really hard to tell where the skin starts and the melanoma stops. If it was benign, it would be a straight line. We can see the diameter of it. If we put it under the microscope at low power and we can't even see the edges of it, that's big and scary. And then we look at other things such as C, it's not a color, but it's confluence. This is a melanoma done with a special stain that we'll talk about in a minute. And all the red cells are melanoma cells. They're all connected in a line. That's confluence, that's bad. Ugly cells present at all levels of the skin or epidermal upward migration is also bad. A lot of times we look, we have to analyze lesions in a way other than the typical pink and purple I was showing you of. That's when you may see in your report, immunohistochemical stains were done, and they all have these acronyms. And these are some of the most common ones that we use for melanoma. These show us the presence of antigens that are proteins that are on the tumor cells that are in some way sensitive and or specific for what type of cell it is. And so as unique to melanoma as we can possibly get. Other things that are done in lesions that are very difficult, don't follow the ABCDE rules, or don't follow the rules for staining us, for the stain positivity, include fluorescence and in situ hybridization. And that is a test that looks for extra copies of genetic material on a slice of the biopsy. It's done in a specialized lab. Here we order it from a commercial lab in Fort Myers, Neogenomics. And it's pretty, even in lesions that are not obviously melanoma, it's pretty good at picking up melanomas. It'll be positive in about 90% of obvious tumors. This falls to about 50% in more tricky lesions. So, we're not going to send a lesion to them that's not, to say, tricky. So you can't always take the result. You sometimes have to take the result with a grain of salt. So you have a bit of a false positive issue with FISH in some tricky lesions. But I use it sometimes. Another test that has become widely used, I've seen in private practice. We don't use it here because most of the time patients come to us already with the diagnosis of melanoma. But that's the gene expression profile test. It started out as MyPath, and now there's a new iteration called DiffDx. And these analyze in a slice of tumor for the presence of either 23 or 35 genes. And again, this test works great on unequivocal melanomas. It works pretty well on unequivocal benign lesions, but it hasn't been adequately tested either in the lesions that really give us agita as pathologists. This is what a DiffDx report looks like, or else I can hold my. It gives you a score. If the score is negative, it's most likely benign. If the score is a positive integer, it's most likely malignant. And all of these things guide what happens, guide the dermatologist in performing a subsequent biopsy. One of the most, what's just a brief mention about the trickiest lesions. This, I see we all have like a group of mature adults here. The most tricky lesion actually occurs in in adolescents or young adults, and those are lesions that are in the spitzoid realm. These are lesions that resemble a benign lesion called a Spitz nevus. And in these lesions, there's under the microscope, there's so little difference between what's completely harmless, and a lesion that may have the potential to spread. I'll show you an example. Even if you're not a pathologist, you can see like, wow, these are two different lesions. They look kind of similar. Maybe the one on the right's got a little bit more pigment than the other. One of these is completely benign and the other one spread and was lethal. And that it was not the one on the right, which to me looks worse. It was the one on the left. So there are these lesions that are very tricky. And we have actually a very powerful test that unfortunately is still quite expensive and not quite widespread. And that's next generation sequencing, where they actually sequence and can detect mutations in up to 500 genes and other RNA transcripts within a lesion. And some of the examples are Foundation Medicine. That's probably the most commonly one done around the US. CARES is another one that may be recognizable. Here at Moffitt, we have our own acronym, the Moffitt STAR test. MSK, Memorial Sloan Kettering, has their own. This is more for the medical audience, but it sort of shows how we integrate all of the acronyms that I talked to you about into a pattern of analyzing them step by step to determine if a lesion is benign or malignant. So now we've come to the near end where we've decided that a lesion is in fact melanoma. So here is again that example of a biopsy report showing melanoma. I showed you, you've got this really long column of things here. What is this? These are the prognostic and staging features. There's a lot of them, but really the ones that really matter are the tumor depth, the presence of ulceration, and the presence of microsatellites. And those three aspects go into the final staging of the lesion. Here's what they actually look like. The Breslow depth is when we have a little ruler in our microscope and we put the 0 on the top of the skin and we measure the bottom of the melanoma. Ulceration is when the epidermis, which is that purple line on top, is completely gone over the surface of it. And microsatellites are super rare. They're when, here's the main body of the melanoma, when you have a piece of melanoma that's completely separate from the main tumor. And those all confer a worse prognosis. We add those findings up to produce a T stage, or in the case of satellites, an N stage. And then Dr. Sondak knows how much normal skin to take around the edge of the lesion when he removes it, as well as does he perform a sentinel node biopsy or not. So thank you for sticking with me for this. And so I hope at the end of this, you understand a little bit more about how many people get melanoma and what happens when one is suspected and how we look at them and guide further treatment. Thanks for your attention.
Any questions for Dr. Messina? You're going to be, you have to leave, right? So if you have any questions, we have a few minutes to take them. I didn't see any on the chat.
No,
Yes.
what the heck?
Good.
What is a gene?
What is a gene?
Yeah, you repeatedly referred to tests referencing sequencing genes, 10 to 12, 25 to 50, 100 to 500. Shoot.
A gene is a code within every single cell that you have, in the middle of the cell called the nucleus, which is kind of the brain of the cell. A gene is a code that can be turned into a protein that will have some kind of action, make your cell look a certain way, be secreted and act on other cells. We all have a common set of genes, and when a mistake is made, when a cell is dividing and growing, which they are constantly all over our body, when a mistake is made in that copying, it has the potential to make a cell lose the ability to know when to stop growing, has the potential to make a cell more aggressive and grow uncontrollably. So mistakes in genes, the more we have in certain genes, are more likely to make it produce a malignant tumor or benign tumor.
Would it be correct then to say that genes cause melanomas?
Mistakes in certain genes, when they're copied, can cause melanoma. And it's typically not, mistakes in copying, which is called a mutation.
Exactly. All right. Can Moffitt perform the NGS test? Yes.
Yes, that's called Moffitt star. And yes, we don't have it as a reference test where you could just get the test by yourself. You would have to have the whole specimen analyzed here, sent here for us to send it to the lab for testing.
Other questions? The other one we'll save because that's covered in the next topic. Other questions for Dr. Messina? All right, thank you again. If we do have questions later, the rest of the panel can also take them, and if we can't answer them, we'll make sure that AIM Melanoma gets the information back to you. All right, thank you again. We're going to move on. I'm going to talk now. We have the diagnosis. What are we going to do about it? Dr. Messina was talking mostly about diagnostic testing. There are also some predictive tests that are used that are available commercially. I'm going to cover some of that as well. Those are my disclosures. And I want to start with saying, what's our purpose? What do we think about when we're doing surgery and treatment? What's the kind of the paradigm that we're using? We start with a localized melanoma, thick enough to have a potential risk to spread. You heard how it's measured under the microscope. And if it gets to 0.8 of a millimeter or greater, we start thinking about the risk of it spreading to the lymph nodes, and we will consider the patient for a wider removal of the primary to get rid of that, and a sentinel node biopsy to check the lymph node. Post-operatively, if the sentinel node is positive, we will usually monitor that patient much more closely than if the sentinel node is negative. We will, around here, try to put the patient on a clinical trial with what we call adjuvant therapy, and that's going to be one of the next topics. What do we do to prevent the melanoma from coming back when we believe there's a high enough risk of it coming back? Dr. Tarhini will cover that. And then if the melanoma comes back, we evaluate today the patient for treatment before surgery called neoadjuvant therapy. You're going to hear a lot about that. That's one of the real frontier lesions. Can we do surgery more than once? Absolutely. Some people wind up having surgery many, many times, but increasingly, if we have a patient where the melanoma has come back, or if they present at a more advanced, non-localized stage, surgery is not any longer the first option. But you're going to hear more about that later on. Because melanoma comes to the lymph nodes, one of the things that we've often had to do in the past and still do today is remove all those lymph nodes, do a lymph node dissection. That's one of the surgeries that we do that's extremely important for taking care of the disease, but has some of the highest side effects of any of the surgeries we do. So today, in 2023, the reason we use this kind of approach of a sentinel node biopsy, of using drug treatments in conjunction with surgery, is to achieve the highest survival and perform as few complete lymph node dissections as we possibly can while maintaining control of the disease where it started and in the lymph nodes. And that's what we're trying to do. How much do we need to take out? How wide of an excision do we need to do? Dr. Messina told you earlier that her measurement tells us how much to take out, and in general, that's exactly right. For melanomas that are relatively thinner, 2 millimeters being the cutoff point, will usually take about 1 additional centimeter in every direction. There are 2.5 centimeters to an inch, so 1 centimeter is less than an inch. In a circle, can't usually, unless we put a skin graft on, we can't sew a circle shut, so we usually make the actual incision as a teardrop shape, which means at least one dimension it's going to be longer than that 2 or 3 centimeter circle. But if the melanoma is bigger than that, thicker than that, we're going to take twice as much, a 2 centimeter margin, almost an inch, a greater chance of needing a skin graft or some other type of more complicated closure than just sewing the edges together. Now, one of the things that's going on at Moffitt today and around the world is a clinical trial to see if that much tissue is really necessary. I think that this is an interesting question, but it is one that will take a long time to get sorted out. And basically, they're taking those melanomas greater than 2 millimeters, or even greater than 1 millimeter with ulceration, which Dr. Messina already told us is a high-risk feature, and saying at random, we will let half of them get a 1 centimeter, half of them get a 2 centimeter margin, and let's see if the wider area is really necessary. We're not talking about that much of a difference, but in some cases, a difference is there. All right. When do we do a sentinel node biopsy? Again, I said we base this on the thickness because that tells us what's the risk that there would be a positive lymph node. That magic number is 0.8 millimeters. Often the pathologist will actually measure it more precisely. So if they say they measure it and say it's 0.7516 millimeters, well, we round it up and that's 0.8 and we do it. And if they say it's 0.749999, we say, well, that would be 0.75. But if it goes down below 0.75, we won't do it. because the risk is too low. It's based on an anticipated yield. We want to find a sentinel node positive at least 5% of the time to justify the risks of the surgery and the accuracy of the procedure. If we get it in that right population who have at least a 5% risk, it's very reliable information, a low degree of side effects, morbidity, and very few people who are told they have a sentinel node that is negative ever reoccur in those lymph nodes, are given that information falsely. And most importantly, the more sentinel nodes we do these days, the fewer lymph node dissections we have to do. How does that work? How does this help? This was the original study of sentinel lymph node biopsy in which, just like that randomized wide excision trial I talked about a few moments ago, a randomized trial, flip a coin, heads you get a sentinel node biopsy, tails you don't. Back in the old days, that was a big question, was a big deal. Today, we don't even think twice. Nobody says, do you want, not most of the time we say this is just what you need, but back then we did not know. Half the people got it, half they didn't. This is the half that got the sentinel node biopsy who have a melanoma between 1 and 4 millimeters in thickness. And you see that if the sentinel node was negative, the blue line, their chance of being alive 10 years later was much higher than if the sentinel node was positive. And it didn't take long to immediately see that difference. Now this was reported already a decade ago and was reported 10 years after the study. So these patients were treated 2 decades ago. A lot has changed since then, but not the relative difference between having a positive and a negative node. Absolute numbers have changed, but it's all relative. And still today, it's very reliable at telling the difference at 5 years, 10 years in your risk of a reoccurrence and even dying from melanoma. Now, I said 5% is the target that we usually use when we're making a decision about a sentinel node biopsy, but that's not necessarily a one-size-fits-all. Older patients with a lot of medical issues, we might say, let's wait for a 10% chance. Let's take the chance that 1 in 20 might have a positive node and we might miss it. We probably want to use a higher cutoff if the risks are higher. The problem becomes, how accurate really are we at being able to tell you have a 10%, you have a 5%, you have a 12%? The answer is probably today not very accurate. We have ways to guesstimate that from the information the pathologist gives us, but we're not very good at it. And we're even worse at finding the rare needles in a haystack. Because if we make a 5% cutoff, but somebody else below that cutoff has a 1, 2, or 3% risk, there's still somebody in there with a positive node. If only we could find them, or at least distill that group. So all of you have a 1% risk, but these 10 have a 5% risk, and the other 90 have almost no risk, then we could target our sentinel node biopsies much better. We are very, very poor at doing this. So below that 0.8 threshold, no agreement on who really is at high enough risk to have a sentinel node biopsy. And then in the middle, there's lots of people who are probably in the 5% group, but they don't have but they're in the 95% of the 5%. If we could find those, even a few of those better, say, yes, overall 95%, but you 100% is going to be negative, we would do a lot better, and we could do fewer surgeries with the same good outcome. So where are we? Are there better ways to estimate this risk? Well, that's what we're trying to find out. And it comes back again to the genes. Dr. Messina talked about it. You asked about it. Genes are what make all of us different, although most of us are our genes are all the same. Most of our genes are exactly the same as genes of primates, much lower on the evolutionary scale. But only a small percentage of our genes are different between one and the other of us, and that controls all the differences in our height, our hair color, our sensitivity to the sun, all sorts of things. And then when the genes go bad, we got additional problems. So there are several gene expression tests that can give a profile. Dr. Messina showed a couple of them, and they can test the genes and tell you, they can test it on the piece of tape. They look for two genes. If one of those two genes is there and it shouldn't be on your skin, it's a sign something is wrong with your skin, okay? The FISH test, the NGS, those are all looking for abnormal genes that shouldn't be there. These gene expression tests that we're going to talk about aren't necessarily looking for abnormal genes in and of themselves. They're looking to see if normal genes are being expressed more than they should, okay? If a cell is growing more than it should, chances are it's expressing genes, proteins, more than it should. There are also some genes that it had to turn off to grow. There are genes that stimulate growth, genes that slow growth down of cells. So there are brake pedals, gas pedals, driver genes, and anti-cancer genes, and the balance of how they're expressed can be informative information. Some of these gene expression profiles out there sort of say, this cancer's bad. All the bad genes are coming up. All the good genes are down. Others are trying to look very specifically. Is there a gene that is associated with spreading of the melanoma just to the lymph nodes? That's a very specific question. What makes a gene, what genes make a cell spread to the lymph node and what don't? If we could figure that out, we could test the melanoma and know ahead of time who needed a sentinel node biopsy, for example. And it's that kind of gene expression test that we're testing at Moffitt today. It's a gene expression test for sentinel node prediction. We are leading a study that will ultimately include over 2,300 patients who are having a sentinel node biopsy. A tiny piece of the biopsy that was already done in the dermatologist's office that Dr. Messina and her colleagues have already looked at, a tiny piece of that biopsy is cut off, sent to a laboratory in California that thinks they've got a test, a gene expression profile that will predict which melanoma spread to the lymph nodes or not. We're putting them to the test. We don't believe it, but we're willing to test it. And we hope this test will give us that magic number. If this test says your number is definitely, positively, take it to the bank, less than 5%, we say, okay, it doesn't matter what the pathologist told us. If this gene expression information is correct, you don't need a sentinel node biopsy. And vice versa. Even the pathologist says this is probably a low risk, but the test could tell us, nope, you're one of the needle in a haystack, high risk. That would be a big change. Right now, we're just under 1,000 of those 2,300 patients have been entered onto this study from about 10 places around the country, about 20 to 25% from here in Tampa, Michigan, and a few other places are joining us. Mayo and Louisville are other big contributors. And so within a year or so, we may well have some real information here. How about when do we do scans? That's a big question. Again, sort of the same question, do we need to do scans? Do we need to do tests? How frequently, how much, how often? In general, at first people think, oh, I want more scans more often. How could that be bad? Well, ask anyone who's ever waited a few days for their report of the scan. It can be quite stressful. But what nobody would ever say is, the more you test me, the worse it is, right? Anybody think that? The more we test, the worse? It is. The more we test, the worse. Oh my God, how is that possible? I still can't figure it out, but it's actually true. This study was done in Australia, and the more they tested patients, this was stage 3 patients with positive nodes, the worse. Now, what we actually think happened is they knew there's something bad about this patient. I got to test her more often. And they must have been right, because the more they tested, the worse that they did. But there was no trend whatsoever that the more they tested, the more frequent the scans, the better the outcome. Exactly the opposite. And the important power of this test was they grouped these patients all together by the sub-stages that we use, not just all stage 3, but 3B, 3C, etc., where we don't know exactly who's better, who's worse, who's higher risk. So the simple bottom line is that it seems intuitive that the more we test, the better, but that's just not true. It's not really going to always give us more information. We have to test, but more and more and more is not better. So it still remains incumbent on us to figure out who needs tests, who needs scans, how often to do it. And this remains a very, very hot topic. This is just the same data analyzed for overall survival to show that it wasn't just older people were getting scans more frequently. It's really complicated analysis, but they couldn't find any reason where anybody who got scanned more often did better than people who got scanned less often. All right, you're going to hear about adjuvant therapy in just a couple of minutes from Dr. Tarhini. That's who needs treatment after surgery. If we can't figure out how to do scans after surgery, how do we figure out who needs treatment after surgery? Well, he's going to tell you how we figure that out. But again, could genes predict? Okay, you've already got it in the lymph nodes. What genes can predict when it's going to come back and when we need treatment? A lot of people are using genes and gene tests for it. And could we pick out the winners? And the bad news is today, no, we can't. We just can't use any gene expression profile to figure out for sure who needs treatment and who doesn't, who needs scans and who doesn't. So we are testing actively a number of different gene expression tests at Moffitt. But if you say, hey, I read about this one, are we using that today to make specific decisions? No, we are not. And the conclusions of a big analysis of all the prognostic gene expression profiles in melanoma that I was a part of a couple of years ago concluded that we're optimistic about the future. We know the genes hold the key. We could only unlock the mysteries of those genes. But today, we've got to be studying them, not just buying these gene tests off the shelf and using them routinely. And so we've still got a lot of work to do. We need a lot more evidence and use these tests only very, very, very carefully, and we like to do them in clinical trials. One last thing I want to talk about very quickly in the last couple of minutes, because it represents a big change. In the past, the only people who got adjuvant therapy recommended were those that had a positive lymph node. Okay, recently, the FDA, based on some clinical trials that you'll hear about, said no, even if you have a negative node, if your tumor is very thick or ulcerated, you might need adjuvant therapy, and it became approved. So adjuvant therapy with an anti-PD-1 drug is now approved for node-negative melanomas that are thicker or ulcerated. So if everybody's getting treatment, do we even need to test their lymph nodes? If the nodes are positive, we recommend treatment. If the nodes are negative, we recommend treatment. Do we still need a sentinel node biopsy? The answer is yes. It's still very important to the prognosis of patients in these high-risk categories, and I won't go over it in detail other than to say the difference between a positive sentinel node is the difference between 60 and 80% or between 24 and 75%. Those are some big differences. To get on our clinical trials, we still need a sentinel node biopsy, but also if we don't do the sentinel node, many of these patients will recur in their lymph nodes despite the treatment, and they will wind up having to have a node dissection that we didn't want them to have, we wanted to avoid. So if the goal is to do the fewest complete total node dissections, sentinel node biopsy is still our most important test, our most important approach. We hope there'll be other ways to get the information in the nodes in the near future, but we're not quite there yet. So in conclusion, in 2023, Dr. Messina and her team, her assessment of melanoma thickness and the sentinel node status is still the most important information that we use for predicting our treatment and understanding the outcome. And a lot of research is still going on to determine how much of a margin to take, when we can use these gene expression profiles to help us predict therapy and other questions like that. So we're going to have time for a question and answer series afterward where all the team can participate. I wanted to get Dr. Messina's questions in because she had to leave, but we're going to go right now directly to the next topic, which is Dr. Ahmad Tarhini. He's one of our medical oncologists, and he is going to talk about these exact issues that I was speaking of. When do we use drug treatment after surgery? And now, when do we use drug treatment before surgery? Ahmad?
Good morning, everybody.
Good morning.
Good morning.
Should get the slides soon. Should I click something?
Yes, click one more time forward.
All right.
There you go.
All right, so we're gonna focus on adjuvant and neoadjuvant therapy for what we call high-risk melanoma. We're gonna talk about this in detail. These are my disclosures. And, I'm gonna start first with a kind of a brief introduction to melanoma stages. We're gonna talk about what we call stages 2 and 3 melanoma, which are candidates for the so-called adjuvant and neoadjuvant therapy. Melanoma staging depends on the primary tumor. Stages 1 and 2 is when the melanoma is on the skin, and the stage is defined by the depth, how deep does it invade into the skin, and whether it is ulcerated. See this erosion in the top of the skin. So stages 2B and 2C that we are interested in for our discussion are the ones that have relatively deep tumor and may or may not be ulcerated as shown here. Now, stage 3 is melanoma when it spreads from the skin to the lymph nodes, which act like filters. So we call it regionally advanced melanoma. The cancer has spread into the lymph nodes, and that's what we call stage 3 as shown there. And then stage 4 is when melanoma has spread from the primary site, from the skin, either to distant lymph nodes or other organs like the lungs, the liver, the brain, etc. Our discussion will focus mainly on stages 2B, 2C, and stage 3. Now, to have an idea, what's the incidence of those different stages? Okay, most patients have stage 1, 75%, and about 15% have stage 2. Out of these, about 7% are stages 2B and 2C. And then we have about 7.5% have stage 3, and 2.5% have stage 4. Now, what is the risk? Now, we're calling stage 2B and 2C and stage 3 as high risk. Why? For stages 2B and 2C and above, the risk of recurrence over 5 years is at least 35%. That's stage 2B, and it increases as the stage increases. And these are the survival rates here. So for those who are, considered stage 2B, 2C, and stage 3, and who are candidates for surgery, we remove the tumor and considered at high risk of melanoma recurrence at 5 years. They are candidates for what we call adjuvant therapy. And then for the subgroup, which is 3B, 3C, and 3D, who also, about 50% of them may also come in with palpable or detectable lymph nodes, either clinically or by imaging. And these are candidates for what we call neoadjuvant therapy or upfront systemic therapy. So adjuvant therapy is post-operative, after surgery, systemic treatment for patients who are considered at high risk for melanoma recurrence. And neoadjuvant therapy is upfront induction systemic therapy for patients with clinically detectable disease that undergo surgery and then followed by what we call adjuvant therapy. Now, adjuvant therapy of melanoma, historically, the first agent approved by the FDA to treat melanoma is what we call interferon alpha. So that's HDIFN, that's high dose interferon. It was approved in 1995. Followed in 2011 by pegylated interferon alpha, another form of interferon alpha. These were the first drugs that we used to treat patients with high risk of recurrence after surgery, adjuvant therapy, but they had relatively limited, let's say, activity, plus they were toxic and had significant impact on the quality of life of these patients. We're looking for newer agents. And, thankfully, there have been a lot of, let's say, work and research that have deepened our understanding of the melanoma biology and the patient immunology, and made us learn that patients with an immune system, and we have these cells that we call T cells that act like the soldiers of the immune system, their activation against the tumor is driven by a balance between different signals. Between different signals, so-called positive signals that activate this soldier, this T cell, and negative signals that inhibit the T cell. So medications or so-called antibodies or monoclonal antibodies have been developed that can manipulate, either stimulate the T cell or inhibit those, negative signals, again, to stimulate the T cell, so it can make more T cells that can fight the cancer. Now, what have made it to the clinic today in melanoma are medications that target CTLA-4, PD-1, and LAG-3. And it was no surprise that the Nobel Prize in Medicine in 2018 was given to James Allison and Tasuku Honjo for their work on the CTLA-4 and PD-1 biology that translated into medications that impacted the care of our patients. Now, just to get a little bit deeper into this, so this is the T cell, that's the soldier, this is the cancer cell. What happens first in the lymph node is this dendritic cell programs the T cell. And we have an interaction between the dendritic cell and the T cell and activates the T cell. T cell is ready now to go and fight the cancer, but then we have CTLA-4 inhibiting its activity. So we have medications, for example, in melanoma, ipilimumab, that blocks this interaction, allows the T cell to go all the way to the site of the cancer and now interact and fight the cancer cell. When it gets there, now we have the PD-1, the other negative signal that the cancer cell can take advantage of to inhibit the T cell activity. And here again, we have medications that inhibit this interaction, allow the T cell to do its job at the level of the cancer cell. So starting with targeting CTLA-4 in melanoma, the drug ipilimumab, the first study that tested adjuvant therapy, again, after surgery, is this study called EORTC 18071. Basically, patients with a stage 3 melanoma were randomized. They either received ipilimumab for a year or received placebo. And the study was positive as shown in the separation of the curves, blue meaning the medication ipilimumab, red is placebo, and patients had improvement in lowering the risk of the cancer recurrence and improvement in their survival in favor of ipilimumab, leading to its approval by the FDA at a dose which was relatively high at the time, 10 milligram per kilogram, which was actually too toxic. We did not use much of ipilimumab because of its toxicity at the time. There's a lot of side effects that resulted from it. So we conducted a study in an NCI-sponsored study that I served as the national chair, is E1609, where we looked at ipilimumab based on prior data at a lower dose of 3 milligram per kilogram, and also the 10 milligram per kilogram, and compared it to the interferon alpha. And we found that the lower dose of ipilimumab, 3 milligram per kilogram, was superior to interferon alpha in terms of overall survival. There was a stronger trend in terms of recurrence-free survival as well. Importantly, we found no difference between the higher dose, 10, or lower dose, 3 milligram per kilogram, in terms of the clinical outcomes, meaning it was as effective based on this study. And the toxicity was much less with the lower dose compared to the higher dose, so supported in cases where we have to use it as adjuvant therapy, that we probably should use the lower dose, the 3 milligram per kilogram. Next is, the data that came with targeting PD-1. So pembrolizumab and nivolumab, both approved by the FDA for the treatment of high-risk melanoma, stage 3 melanoma after surgery. The first study, this one shown here, Checkmate 238, tested nivolumab versus the ipilimumab. And this study was positive in favor of PD-1. So now we have learned that nivolumab is better than ipilimumab and was also significantly less toxic as well, leading to its approval by the FDA. So now we rarely use ipilimumab as adjuvant therapy. We use nivolumab. Now, we did not see improvement in survival between the patients as part of the study when comparing these two, essentially active drugs, but the risk of recurrence-free survival was significantly improved, so definitely it is a superior medication. Similarly, a similar study, Keynote 054, tested pembrolizumab, the other PD-1 medication. And this study compared to placebo, as we've seen in the prior study, was also significantly positive. So pembrolizumab was better than placebo, again, significantly reducing the risk of recurrence, improved recurrence-free survival, leading to its approval by the FDA. So as I said, we have now both pembrolizumab and nivolumab approved by the FDA for stage 3 melanoma as adjuvant therapy. But these are, as I said, associated with side effects. We have activation of the immune system to fight the cancer, the melanoma. And this also leads to the immune system affecting normal tissues that can affect any organ in the body. And as I said, the risk was higher with ipilimumab and lower with anti-PD-1. So these are things that we keep an eye on, obviously, when we treat with these medications and to manage the patients. Now, moving away from immunotherapy, what about the tumor biology? What about targeting defects within the cancer cell based on the tumor biology? So if this is the cancer cell here, the cancer cells are driven by certain pathways that stimulate their survival. So one cell divides, becomes 2, 2 become 4, 4 become 8, etc. In melanoma, about 50% of patients with melanoma, their melanomas have a defect, a mutation in the DNA of a protein called BRAF, as shown here. So this mutation or this defect in this genetic code results in this abnormal protein that now acts like an engine, which is firing out of control, regardless of upward stimulation. Usually a normal cell, you have this stimulates this, etc. And then the cell grows. Here, it's an engine firing out of control, right? And the cell is growing and dividing and making more cancer cells. So we have medications, so-called BRAF inhibitors, that can block this protein or kinase or abnormal engine. And we have learned that if we have 2 blocks, so we block BRAF and the protein below it, you have even better activity. And this was tested in, you're taking a photo?
Yeah.
Should I wait?
No, you're good. I got it. I got it.
All right, so the study, the next study, tested the BRAF inhibitor, dabrafenib, and the MEK inhibitor, trametinib, also as adjuvant therapy, also for stage 3 melanoma, and compared it to placebo. And the study was also positive, was significantly better than placebo in recurrence-free survival, leading to its approval by the FDA. When looking at the overall survival, also a strong trend, was not statistically significant, but a strong trend in favor of treatment. The side effects are different from those that we see with immunotherapy. These may include fever, fatigue, nausea, headache, chills, diarrhea, mostly manageable, although in about 25% of patients, we may have to stop short of the planned treatment, which is usually a year. All these medications are given for a year. About 25% here, we have to stop short of a year. With the immunotherapy, it's roughly about 10% may have to stop short of a year because of the side effects. Now, next is the stages 2B and 2C. So the lymph node is negative, but we said we have 2B and 2C, risk of recurrence over 5 years. With the 2B is roughly about 35%, with the 2C roughly about 40%. And this is the study, the so-called Keynote 716, that tested pembrolizumab, the PD-1 antibody, versus placebo, and the study was positive in favor of the pembrolizumab, leading to its approval by the FDA. So this is now available in the clinic, and we're offering it to patients with the stages 2B and 2C. More recently, the other drug, the other PD-1 drug, nivolumab, was also tested in this study called 76K, also compared to placebo, the same endpoint, recurrence-free survival, and the study was positive. So this is, again, kind of supports the activity of these PD-1 antibodies in patients with the stage 2B and 2C melanoma as an option that, can be offered in the clinic. So, moving on next to neoadjuvant therapy. So I said this is the distribution of the different stages of melanoma. Now, for those patients that belong to stage 3 and present with bulky disease, that we said maybe the surgery is too morbid, maybe the surgery may not, help these, maybe the surgery should be delayed, after upfront treatment. We estimate based on prior studies, for example, this study that tested pembrolizumab and this study that we conducted with ipilimumab versus interferon, we found that, what we call macroscopic lymph nodes, meaning those that we can see them on the CT scan or those that we can palpate them on the physical exam, are about 50% roughly of the stage 3. So 50% of these 7.5% may present with these bulky diseases that possibly maybe we should try immunotherapy before, stimulate the immune system, or targeted therapy before, kind of shrink the tumor, potentially make the surgery easier. And that's what we've been doing. So I, kind of conducted the first ever CTLA-4 or so-called immune checkpoint inhibitor neoadjuvant study that we published at the time in 2014 with a drug called ipilimumab, and a lot of work has been done by our group and by many others looking at this neoadjuvant approach in many studies. Recently reported very promising data with this combination. This is a national study which is ongoing as well. And there is a lot of, very exciting data that came out in a small study, relatively speaking, with pembrolizumab, nivolumab, ipilimumab plus nivolumab, and relatlimab plus nivolumab. So meaning what we do here is, we see the patient with bulky disease, we enter them into the so-called neoadjuvant phase. We give treatment upfront, right? And then we wait for a certain period. It could be 6 weeks, could be 10 weeks, 12 weeks, depending on the study. Next is the surgery phase. So we get neoadjuvant phase. Next is the surgery phase where we do the surgery, usually watching the tumor, ensuring it is responding to the treatment, followed by after surgery, by the adjuvant phase in most patients. So we have the neoadjuvant phase, surgery phase, and adjuvant phase. And this has been a an important topic and discussion, let's say nationally, started in melanoma and has been, spreading across many other malignancies. The National Cancer Institute Early Drug Development team asked me, last year to invite a group of investigators from other cancers, those that test head and neck cancer and lung cancer and GI cancer and so on, where we put together a workshop and published what we call a position paper now, inviting everybody to test neoadjuvant immunotherapy in solid tumors across different malignancies and provided guidance how to design these studies and the endpoints and so on. Importantly, in melanoma, in this landmark study that Dr. Sondak played a leading role in, it was just published in the top medical journal, New England Journal of Medicine. Patients were, this study was conducted by the Southwestern Oncology group, and patients with bulky disease were randomized to either get adjuvant treatment, meaning you just have surgery up front and get 18 cycles of the PD-1 inhibitor pembrolizumab, or enter the neoadjuvant phase, meaning you get 3 cycles of pembrolizumab over 3 weeks, meaning over a 9-week period, followed by surgery, followed by 15 cycles of pembrolizumab as neoadjuvant therapy. The main endpoint that they looked at is event-free survival. So progression or toxicity, failure to begin the adjuvant therapy within a certain period of time, melanoma recurrence after surgery, or death from any cause. The study was positive in favor of neoadjuvant therapy. It came on top, meaning, and this is a national randomized study for the first time now demonstrating head-to-head significant improvement with neoadjuvant therapy over adjuvant therapy, all right? So these are now my conclusions. So adjuvant trials of PD-1 with nivolumab and pembrolizumab and BRAF/MEK inhibitors, specifically the BRAF and trametinib, have now changed the standard of care for stage 3 with significant recurrence-free survival improvements. This is the standard of care in the clinic. Significant also recurrence-free survival improvements with adjuvant anti-PD-1 has been seen in stages 2B and 2C with both pembrolizumab and nivolumab. Important to say that pembrolizumab is currently approved by the FDA. Nivolumab is under review by the FDA. It's not approved yet. Neoadjuvant therapy, in my opinion, has become the standard of care for these patients with local regionally advanced melanoma. Now, ongoing studies by our group and others will define what we call the most optimal combination regimens in the near future. Biomarker-driven patient selection for adjuvant and neoadjuvant therapy is an area of active investigation. We have a lot of work in this area, and we believe this will also change the standard of care in the coming few years. Thank you.
So again, everything we've talked about so far in this morning's presentations has been about the patients who've come in with melanoma localized either to the skin or the lymph nodes, trying to predict who was at high risk and treat them appropriately. After the break, after the Q&A session, we were going to talk about patients where the melanoma has already spread, how we treat them today, how we're going to treat them in the future. But we've got time. We've got about 15 minutes or so to take any questions, both from the audience here and from anybody out in the virtual audience. Okay, one right here.
Sure. How accepting are the insurance companies to the adjuvant therapy?
They are. It's a standard of care. It's approved by the FDA. They have no, if you say you want it, they have no choice.
I see.
Now, of course, that's not for everybody, but for those stages that are at high risk, stage 2B, C, 3, in general, we have not had problems with it. And just, there was a question there about the generic and the trade names. We use generic names, pembrolizumab, nivolumab, ipilimumab, relatlimab. Tell us what the other names are.
The question is, which immunotherapy is Opdivo? That's nivolumab. So Opdivo is nivolumab. Keytruda is pembrolizumab. Yervoy is ipilimumab.
Any different, what are the differences between
So
Keytruda
Keytruda and
and
they're the same, they're twins, in my opinion.
they're given a slightly different schedule, right?
True. So as far as the schedule, we talk to patients in the clinic. So pembrolizumab or Keytruda as adjuvant is approved to be given every 3 weeks or every 6 weeks. Nivolumab or Opdivo is approved to be given every 2 weeks or every 4 weeks as adjuvant therapy.
All right, and then we'll get more into the individual data about single agent PD-1 combinations with the newer drugs that target LAG-3 for metastatic disease in a little bit. There's a question about some of the factors that increase the risk for melanoma. That is one thing that we didn't really address a lot this morning. We've talked in this symposium almost entirely about people who already have a diagnosis of melanoma. And certainly here at Moffitt, we see people across the entire spectrum of age, skin color, everything that contributes to the risk of melanoma. There's a specific question about which cancers contribute to an increased risk of melanoma. And interestingly, I would say the number one that we see is cancers really that reduce your immune system. And they're not that many. Most cancers, breast cancer, prostate cancer, even lung cancer, they don't reduce your risk of, reduce the strength of your immune system in and of themselves. Their treatment might. Some of the leukemias, especially the chronic leukemia, CLL, that's the number one type of cancer where we see a dramatic increase in the risk of melanoma, other skin cancers like Merkel cell cancer, and so forth. And sometimes we diagnose the CLL because we take out the lymph nodes, do a sentinel node biopsy, and Dr. Messina calls up and says, hey, there's no melanoma in that lymph node, but the patient has CLL. That's probably why they got the melanoma in the first place. Fortunately, that's quite uncommon, but Moffitt's a big center for taking care of CLL, and we have a lot of those patients as well. So there are many, many predisposing factors, but most forms of cancer do not. Now, there are some questions about the BRAF and MEK inhibitors. Should we give one or both? You're going to cover that a little bit later, so we're going to put that in part B. But let's go back and say if a patient has a choice, they've had the positive sentinel node or they've had positive nodes removed and they have the BRAF mutation, should they get immunotherapy or targeted BRAF
In the
therapy?
adjuvant setting, in the
For
adjuvant setting.
prevention, exactly.
Yeah, in the adjuvant setting, the data is comparable, in my opinion, between immunotherapy and targeted therapy. The studies are positive, so we offer the patients the different these medications. We talked about the side effect profile and the ease of taking. So one is given IV, let's say every 3 or 6 or every 2 or 4, and that one is a pill. So we talk about the side effects. They're equally effective. Now, there's a study that we conducted nationally and looked at immuno versus targeted in metastatic disease and showed that when we give immuno up front, patients do better. And we leave targeted as a salvage backup option. So that study was done in metastatic disease. Based on that data, we may have some bias towards immunotherapy first, but we don't have that, that direct comparison in the adjuvant setting. We have it in the metastatic setting.
We'll talk more about that a little bit later. Okay, so I'm going to save that one. Now here's a question about the number of lymph nodes when we do a lymph node dissection. How many lymph nodes are there? And the short answer is it's completely variable from one person to another and even from one part of the body to another. In general, the neck dissections, we see the highest number of lymph nodes, very small lymph nodes, but lots and lots of small lymph nodes in the neck. 40, 50 isn't unusual. We've certainly seen over 100. That's something we would never see in pretty much any other part of the body where we remove the lymph nodes. In the armpit, anywhere from 10 to 30 or so. In the groin, usually we're talking about 8 to 10, 12, maybe 20. So very variable, and not even the same from one side to the next. And it's not really the number of lymph nodes that we remove that's important in your decision-making. It's the number that are positive. How does that affect your decision?
Well, I think the higher the number of lymph nodes that are involved, the higher the risk of melanoma recurrence. So we are more likely, to recommend that. We recommend it for everybody that, let's say, meets the criteria of the studies that we presented. But the higher the number of lymph nodes involved by melanoma, the higher the risk of, in terms of recurrence and, survival.
And let's go back to that question about how often to get a scan. If you're in stage 1 or 2 or 3, what are you recommending?
On the national studies that we, let's say, designed and did and participated in through the industry, the schedule that we do is every 3 months for a year, every 4 months for the second year, every 6 months up to 5 years. And we don't like it, honestly. I mean, we would love to have a biomarker like ctDNA that we can compare head to head with, with radiologic imaging and see maybe we can skip SCT at 3 months and do it every 6 months. But the standard now, based on those studies, is every 3 months for the stage 3 for a year, every 4 for the second, every 6 up to 5 years. Now, for the stage 2B and 2C, the schedule is every 6 months. That's how it was on the studies.
All right, other questions?
Yeah, can I ask,
Yes.
you talked about PET scans and CT scans. What's the difference?
Well, the PET scan is a CT scan, which is combined by another study that involves let's say, a radioactive contrast. Basically, it is so-called FDG, which is it is a glucose molecule which is tagged to a fluorescent substance. So it's injected and it goes and it lights up everywhere that the glucose is taken. The cancer obviously is growing quickly and it needs energy, needs glucose, needs sugar, so it lights up. But it also lights up in other parts of the body. The brain is active. The brain lights up a lot on the PET CT scan. That's why it's not a good study to look at the brain, for example, for melanoma. So it gives sometimes more information in specific cases. So we decide on a case-by-case basis. But many times the CT scan, which is, like essentially an X-ray, which is taking sections in the body every 5 millimeters, may be good enough and gives us enough information. It is less toxic, less radiation exposure. But we weigh the risks and the benefits and what is needed, what information we're looking for in deciding between a CT and a PET.
Okay, thank you.
Good. Yes.
I have stage 3C melanoma with BRAF, and Dr. Sondak done a groin dissection in 2018. And since then, about once a year, I have to have a melanoma removed, 1 or 2, but they haven't had to, inpatient, outpatient surgery. And then now I've started having extreme problems with my lymphatic system. And I'm just wondering if that's...
So the melanoma that they remove, is it a new melanoma or related to the old one? Is it metastases or is it a separate
It
primary?
had metastasized before on my sides and stuff, and that's why I came down
So
to this.
new metastases.
Yes.
So, it's obvious that you have an active immune response that is fighting the melanoma and keeping it away from the major organs. So it is active. So you come up with these, let's say, recurrences that happen every year or so. It means your immune system is working, and the best way is to minimize exposure to systemic therapy most of the time, maybe give you medications and just have a simple
I've
excision.
done the therapy for a
So that-
year's time.
And then,
I forget what it's called, Trifol.
TVEC.
I've done it for a full year and it seemed to
I
work.
see, yeah.
But then they keep coming back.
You
And
got the
my
adjuvant.
main problem I'm having now is my lymphatic system is just going crazy. I
So
mean,
meaning your limb, where you have the
no, it's
dissection,
going through my body now.
you think the lymphatic system,
Lymphedema is going through.
Got it.
I'm really having a lot of problems with it. I didn't know if that may occur or may go
Probably.
away or.
well, I mean, it's it's hard to tell, for me to tell what is happening exactly with you. That's something you can be discussed maybe one-on-one with Dr. Sondak. He'll give you the best advice on that.
Thank you.
All right. There's a couple of questions about if someone was initially at low risk, but they either get another melanoma or another skin cancer. What does that say about their risk of the melanoma coming back? Do we treat those people differently?
No, I mean, we treat only the highest risk melanoma. So we may give adjuvant if the highest risk melanoma, the worst one that we got is a stage 2B, 2C, or 3. But those who are separate primaries, they're not related to the one that we had before, we treat them as a brand new melanoma. Now, we've been in the sun, we may have been in tanning beds, so we're at risk of getting those for the rest of our life. That's where we have the prevention in terms of self-skin exam, once a month, keeping up with the dermatologist, skin examinations, possibly with the family doctor when you go for your, checkup, let them look at the skin. That's where you need to catch it, maintain that prevention and catch it early.
And I always say the sun doesn't shine in just one place. So we are very, very frequently seeing people with multiple skin cancers, multiple melanomas. That in and of itself doesn't make a worse prognosis for any one of them, but it does indicate a need for close observation, including.
And each time another melanoma is removed, does that mean you start over your new, I guess what you call date on?
Depends, would depend. If it was a more serious one, absolutely. Yep. All right, do satellites have a worse outcome? And if somebody just had a satellite on the path report, nothing in the sentinel node, would you treat them with an adjuvant therapy?
We do. So the satellite means that the melanoma has made it to the lymphatic system. So we call it in-transit metastasis, meaning it's going through these lymph ducts into the lymph nodes. So it's already, let's say, spreading. So yes, it makes it stage 3. When we see a satellite, means it's already stage 3, and we treat with adjuvant therapy. And one of the studies specifically looked at those patients with satellites. So the study with nivolumab, for example, had a specific analysis for this and showed, yes, the significant improvement in reducing the risk of recurrence with PD-1 blockade. We did this also in the study with ipilimumab. We showed this also with the satellites that we have improvement with ipilimumab compared to interferon. So there is data to support treating these patients with adjuvant therapy.
And then in terms of adjuvant therapy, we'll talk about this differently for metastatic disease. The combinations of immune therapy, ipi-nivo, the Opdualag, nivo, relatlimab combination, do we use those in adjuvant therapy yet?
Not as a standard of care. So the study that tested Opdivo plus Yervoy, or Ipi plus Nivo, had a lower dose of Ipi and came back negative. It was not better than nivolumab or Opdivo by itself. Now there are studies, and we're getting very close to open one of the national studies that has a combination immunotherapy compared to monotherapy, just one drug, PD-1. So these are investigational only on clinical trials, but not outside of clinical trials.
And how about the 3 or 6 week dose for the pembrolizumab Keytruda? For adjuvant therapy, which one do we use here?
We offer both to the patient. So just to explain this better, so we give pembrolizumab over a year. If we give it every 3 weeks, we give it at the dose of 200 milligram. If we give it every 6 weeks, we double the dose, so it's 400 milligram every 6 weeks. For the patient, it's less visits to the clinic. Now, the data supports, let's say, similar activity and let's say similar safety profiles. So we offer both to the patients. Sometimes we start with the 200 every 3 weeks for 4 treatments. And then if it's well tolerated, no major side effects, and the patient wants to go on a longer, interval, then we switch it to every 6 weeks at that time.
And last question here, that Opdualag combination, nivo and relatlimab, for neoadjuvant therapy, it's not approved for adjuvant, and we don't use it outside of a trial. There was a study of it in neoadjuvant before surgery. Are you using that for neoadjuvant therapy?
So it was a very interesting study that was, showed promising data, small study, about 30 patients. And, showed that, upward of 50% of patients may achieve what we call a pathologic complete response, meaning at the time of surgery, we don't see cancer. It's very promising. If the insurance pays for it, yes, we offer to the patients.
All right, we're going to take a little break. We're going to start again promptly at 10:45. And that will be with these metastatic disease treatments.
Coffee and food outside.
We want to try to keep everybody on schedule and get everyone out of here on time. So again, I want to stress that what we have been talking about in the first half of the presentations are cases that are localized, trying to prevent the melanoma from coming back. We were talking about what we used to believe with interferon, and it actually turned out to be true. We were trying to kick the can down the road. We knew the drug didn't work that well. We knew it was a crude and toxic way to boost the immune system compared to the treatments we have today. But we were just hoping that if we could get a few years more science, a few years more clinical trials, that new drugs would come along and that they would have better outcomes, fewer side effects, better results. We had no idea at the time how successful those trials would be, and frankly, they've exceeded all of my expectations. I never expected to see in my career the advances that we've seen in the treatment of widespread melanoma. So despite everything we do surgically, despite adjuvant therapy, still some patients develop widespread disease. Very rarely somebody shows up, never knew they had melanoma at all, and already has metastatic disease and needs treatment right from the outset for widespread disease. That's what we're going to talk about in the next couple of presentations.
Before you get started,
Yes.
is interferon
Yep.
kind of what followed the traditional chemo?
Interferon was not a chemotherapy, no. Interferon was
Yeah, was that kind of the start of moving in a different
first
direction?
type of immune stimulating drug, but a very, very general one. Dr. Tarhini showed that picture. You might see it again from Dr. Karpetian of the T cell and trying to stimulate one molecule on one specific kind of immune cell. Interferon was a shotgun blast to try to stimulate the entire immune system, and with it, a lot of side effects. Anyway, Dr. Karpetian is one of our newest oncologists, and we're very excited to have her with us. She's been an expert on some of the newest drugs that are now available, and she's going to tell us about all of them. This is
the
the one that goes forward, and the one on top is the pointer.
So thank you all for joining today. So I wanted to talk a little bit about first what is stage 4 melanoma. And when we think about stage 4 melanoma is really the melanoma that is spread from original part of the melanoma to other parts of your body. And the thinking about how to treat that melanoma is really dependent on what is the extent of tumor. And what I mean with extent of tumor, let's take these two. And here you see a person who has melanoma in different parts of the body. And this can be skin, this can be inner organs like your lungs, your liver, and it can involve also to the brain. Whereas here we see the person who has one melanoma that is in the lung, and this is presumed to be melanoma that is spread to the lung. These both are considered to be a stage 4 melanoma. The first question that comes to the discussion is this a melanoma that is only one part of your body and potentially in one organ, such as in this case we see a lung, or this is a melanoma that is spread actually to different parts of your body. And why is this important? Because despite the fact that both are called stage 4 melanoma, management differs. And in this case, we potentially can use the options that Dr. Tarhini discussed previously, like a surgery, maybe at some point a radiation, of course, combined with some drugs, medications. But here is the case when you have a much more opportunity to discuss with what we call medical oncologists that treat the melanoma with the drugs. Today during my talk, because the time is very limited, We are going to focus type of melanoma that we cannot do a surgery because it is spread to different parts of your body. And the best way to treat it is actually the medications that can go throughout whole your body and affect different parts of the melanoma that are located in various organs. So why do we treat stage 4 melanoma? One and most important thing is really something that we call overall survival. And what does that mean? It's really the goal is that you live longer and with the assumption that that life is going to also have a good quality of life. So because it's always very difficult to do some drugs, study drugs that will follow you whole your life because your life can go 5 years, 10 years. We do some what we call surrogate points that we assume that if these surrogate points are good, then it eventually is going to impact how long you live and how good you will live. And a lot of times when you'll hear your doctor talking about this, doctors will mention something which is called progression-free survival. What this really means, we assume that medications are going to decrease, that melanoma will get bigger, it will progress in your body. And often we hope that if the drugs affect this progression-free survival, the progression of a disease, they are eventually going to affect your overall survival. Make you live longer. And the next thing that is really something that we focus as well is what we call response rate. And what does that mean? Look at the first picture when we see a big melanoma, and we assume that when we incorporate a drug here, the medications make your melanoma to shrink. And these two are something that we call a good success of a drug. And it's something called response rate. And when we see in the first picture, this is a significant tumor shrinkage. Tumor got smaller when we look at the first picture. And in the next picture, this even disappeared, what we call a complete response. So we often use these two when we test the drug because we believe that these two are going to eventually impact your life. And this is the most important thing that we think about when we treat it. So now, the way we think about treating melanoma, so this is, think about this is a tumor that is in your body. And we also assume that your tumor is surrounded by something which we call immune cells, your immune body. So the way we treat nowadays melanoma with the medications, there are two important things that we assume is ongoing in your melanoma. The one thing is really the way that we can actually boost your immune system to affect the melanoma and make it shrink or go away. So this is one part that we assume will work. And here you will see that sometimes this immune system has some brakes on it that doesn't allow your immune cells function well. And here is why we have all of those medications, that all of this class of medications will affect your immune system and make it take the blockage away and make the immune cells to work well. And here I have the drugs. Often as a musician, we like to use the real name, but the patients get advertised for the trade name that you hear in a TV or something like that. So I often tell you both, so you remember what we are talking about. So here you will see Keytruda, pembrolizumab, Opdivo, nivolumab, Tecentriq that we use only in some circumstances, Yervoy, ipilimumab, and here I have a relatlimab plus, which is the Opdualag. And I have a plus sign here because Opdualag combines both relatlimab as well as the nivolumab. It's a combined medication. And you will see here one other thing that is important, that I classify this as a three components because, like, for example, you asked the question, pembrolizumab, nivolumab, these are same class drugs, so there's not a real difference at the best of our knowledge from their action. Now, Next part, the way how we think about melanoma is not just the immune system. That around 40 to 50% of patients also have a melanoma that has something which is called BRAF, B-R-A-F. And this is a type of thing that helps us to incorporate some other types of drugs which are called targeted therapies. And the targeted therapies are not immunotherapy. They are type of therapies that affect this BRAF just because this melanoma is driven by BRAF to grow. And here you will see 3 different combinations. We often use these together, such as one is the BRAF drug, one is the what we call MEK drug. And you will see your provider providing 2 drugs. There are 3 of those combinations that are available in the market. They again have their real names and they have their sort of pharmaceutical names. So I have it here in case you wonder what I'm talking about and what do I refer. So to summarize, thinking about how we treat the melanoma, we incorporate the immunotherapy, and we incorporate for patients who have this BRAF, because again, not all patients have some type of target. Now, I want to highlight that amount of progress that has been made for treatment of really stage 4 melanoma, and here you will see starting from 1980s, going up to the nowadays, there are so many medications that have been tested and eventually approved and are being in a clinic. I have some check marks here, and I really don't want you to focus on those because I don't believe that any of us are using this as a single agent or interleukin-2 and etc. for reasonable reasons that we will not focus today. I have some question marks here that you will appreciate, such as this combination, which is a combination of immunotherapy and targeted therapy. Or I have some question marks here, like for a TVAG, or I have a single drugs here, like pembrolizumab, ipilimumab, single drug, nivolumab, single drug. And the reason I have that, because I think we as a physician have to ask ourselves a question, why that was made as a choice to treat you. And I have some stars here that I believe that these are the most common ones that you are going to discuss with your physician. And now I will proceed with explaining why I think these are real stars and why we should focus on those. So why do we need to choose what we call nivolumab, ipilimumab for patients? So nivolumab is Opdivo and a Yervoy, because we know that for a very long time of follow-up, and I point here out 6.5 years of follow-up, 49% of patients were alive. We also know that the very long follow-up, remember I told you this is important, progression-free survival, 4% of patients were having no disease progression. And to highlight, while this study was not done to right away compare what is better, the combination of these 2 drugs or only the 1 drug, we also got some data about how single 1 drug is working. And one other important thing that we came to appreciate from this study, that patients who have what we call this BRAF that you saw in the beginning, this difference, 2 drugs versus using, was much larger that we appreciate, like 38% versus 23%. Now, when we look at what does it do with the tumor to go down, we see that in 57% of patients, this tumor actually shrinks or even disappears in 11.5%. Now we move even forward, and this is also an important factor, that what if you discontinue the drug for some reason? You can see here that the time for this combination therapy was actually the 27 months that you were started on a new medication. And why this is important? Because it will come at some point that you have to discontinue the drug for some reason, and I will tell you in a subsequent slide. And I often tell my patients that even if you discontinue the drug, see, there is still some timeline that patients actually did not need to start on a new drug because the effect of that therapy was continuing. Now, we even know that patients who have disease in their brain, this combination therapy works for that as well. And if you look at separately what happens in the brain, tumor shrinkage or even disappearance happen in 54 and 33% subsequently. So it does work in the brain as well. And obviously at the largest follow-up data 3 year, we also know that even at the 3 year overall survival was 72%, meaning that even patients who have a disease in the brain, this combination therapy works for them as well. Now, well, if this is such a great combination, why don't we use this for all patients and we discuss alternatives? Well, because there is something that is also important and affects your life and affects your quality of life, which is called treatment-related adverse event, treatment-related side effects. And here we see in a different arms that we see, these are the patients who receive combination therapy and these are patients who receive only one drug. You appreciate here that almost not all patients develop some side effect. And on half of the patients, even more, they develop actually severe side effects. And you also appreciate that amongst those who have a bit severe, 29% actually discontinue the drug because of side effects. So this is important to discuss because this drug might work really the best, but it also causes a lot of side effects, which can eventually impact your survival. So when we think about what are the alternatives to explore in those settings, then we do not feel comfortable with this number. So another combination that is more recent is the combination of nivolumab and relatlimab, which is the same as Opdualag. And this is a relatively new medication in comparison that we have from Yervoy and Opdivo. And we here see that at the 3-year markup, 56% of patients were alive. And this study was actually specifically designed to compare, is one drug better, only Opdivo, or 2 drugs better? So, and study did confirm clearly that 2 drugs are better than 1 drug. And then you will see here that the 50% of people actually with median PFS, what we call progression-free survival, was definitely better, like 10.12 months versus 4.6 months. And if we further look what did it do to tumor, in 43%, it did make the tumor go down, and 16% even completely disappear. So when we ask the question, obviously, what is the side effect that we get? What is the percentage? Because we know that the other drug works well, but also has some very significant side effects. And here we appreciate the fact that it's only like 21% of patients actually developed high-grade side effects, really severe side effects, leading to discontinuation in 9% of patients. And if you recall the same number from other drug combination, it was 55%. So this is the time when we think about, when we value this risk of a side effect for patients and we discuss with them, we may actually choose to go with this combination rather than going with a combination that may have a higher of a side effect. Just to highlight that, I also would like to point out that this risk is not as high when we appreciate the benefit what we get from combination therapy. Here is why a lot of times we choose actually to go with the combination of Opdualag rather than single drug, what we have nivolumab. Now, one may think if this is the case, why we shouldn't take the drug that has less side effect and try that, and then if the patients develop any disease does not get better, maybe we can use the drug that has a high benefit but also high side effect. So why we should choose to go with that high side effect, high benefit in the beginning? So this is where it comes. Very important to understand how each of those drugs work if you were to get another drug. I do have to highlight that although we don't have a very good clinical data, at some degree we understand that the same drugs, if were given after one was already taken, they don't work as great as they used to work when they are given as a first line. Here's why we often think to go with the best regimen at the first line when you are diagnosed with melanoma. So now let's talk a little bit more about targeted therapy. As I mentioned in the beginning, there are 3 combinations, and you often will receive 2 drugs. There is not one drug. We often receive 2 pills which affect different molecules, but they have to be combined together in order to work better. And these 2 combinations have not been head-to-head compared. So if you ask us a question, yes, something they do appreciate in one over another 2, but they have not been compared which 2 are really great. However, we know what the data we have for them. So there is something important about these drugs, that they still result in a very high percentage of a tumor shrinkage or even complete disappearance. And there are some times that we really want to use a drug that has a higher chance for your tumor to shrink and, more importantly, quickly to shrink. And these are the drugs that are really important for that degree. We also have a data when you will follow up at a 5-year landmark. So how much do they help the patient? And while we here appreciate that something with a combination of what we call Braftovi, Mektovi, same encorafenib and minimetinib, they have some degree of a longer time of what we call disease progression, like 14.9 months, in a comparison to this numerical number 11.1 with a combination of dabrafenib and trametinib or combination of emorafenib, cobimetinib. There are no head-to-head comparison. So you can see potentially all of these drugs being used if your tumor has something which we call BRAF. What we really also do is sometimes discuss the side effects that you can develop from these drugs, and they can vary, and they can be in a little bit of different degree. Like an example can be if you take the dabrafenib and trametinib, fever is a big issue, and some patients may not really like that. So, and that could be a good reason not to choose that. Or, for example, I had just recently a patient who developed eye inflammation, which is called uveitis. Although they are still all of these drugs may cause some eye issues. Sometimes with combination encorafenib and minimetinib, Braftovi one, can more a little bit of high of eye that uveitis. So we often discuss each of those with the patient, and we come up with a plan that is safe from a side effect standpoint as well. Now, I would like to point out that there has been a lot of discussion, well, if for patients who have both choices, where to start, which drug to use first, because technically if you have BRAF change in your melanoma, you can both use immunotherapy as well as targeted therapy. And in 2022, this is an important study that shows, and we use these curves a lot in evaluating how drugs work. And here you will see this axis really shows the months, and this shows percentages, proportions. Now, blue line shows here when you start with immunotherapy and you switch to targeted therapy, which is the BRAF molecules, then your disease actually progresses when you are on immunotherapy. And a red line shows that you start with the targeted therapy and then you switch to immunotherapy when your disease progresses. And I always tell you, the most important thing is really the overall survival, how long you live. And this study was done specifically to show which one is better to start in the beginning and continue when you have a disease progression. And now let's take a look on these 2 curves. And at the 24 months, 2-year markup, when they evaluated what is the outcome for patient, there is one clear fact appreciated that patients who started with immunotherapy in the beginning and continued on targeted therapy did almost 20% better than patients who were started with the targeted therapy and switched to immunotherapy. Here is why, in contrast to stage 3 disease, when we explained that these are comparable, we discussed both of those with you. Now that we have this data, you will hear your medical oncologist offering more of a starting with immunotherapy, even if you have a BRAF mutant disease, and as long as you have no other contraindications to immunotherapy, and when switch to targeted therapy. So this data is important, but there is something we obviously appreciate here, that when you look at the beginning of curves, higher the curve, better the outcome. So you look here that in the beginning, very beginning in the first 10 months, you will see actually the high red curve, red line was even higher than the blue line. So it was optimal in the beginning. So we often ask these questions, who are these patients? Because even though when we look at a clear landmark 24 months, we do tell that immunotherapy is better, these are still very important patients who did not follow the overall goal of this overall outcome of this trial. And we propose some reasons, and one of those can be that when you see patients that have a very, very large tumor in your body, and if you recall that picture when you have a tumor and around immune cells, sometimes when immune cells are small and the tumor is so large, and your immune system may not overcome that large tumor that you have in the body, or when we have such amount of a tumor that we really need to quickly shrink the tumor, these might be some of the times that your doctor may prefer actually to start the targeted therapy first, and then potentially switch to immunotherapy later. And we even have a clinical trial in Italy showing that that's a feasible approach to do. So while the summary will be, we will start by the rule with the immunotherapy nowadays and switch to the targeted therapy. Remember that there may be cases, because we appreciate this in the beginning, that some patients do not really benefit from this approach. And while we do not know who those are clearly, there might be cases that your doctor will prefer to start with the pills and then switch to the immunotherapy. Now, I would like to summarize again how we treat the stage 4 melanoma. Now, as we highlighted all, it is very important to know your BRAF status. While nowadays we often do the extended analysis like we spoke, we want to learn about all your tumor, but this one is crucially important. Every patient should have this. And regardless you have BRAF mutant disease, or you have what we call changed in your body, or it is not changed, there are several things that we think about before treating. First of all, your preference. We discuss all of the adverse effects. We discuss about your general health status, how much other medical problems you have, and how important is it for you if you were to develop side effect, how much is that going to impact your life? And we think about, is your disease actually in the brain? Is your disease a little bit of that unusual place of a melanoma, such as melanomas can be also under your food, in the gut, or there are specific types of melanomas, or how big is your tumor, how much liver is impacting, or some of a marker that you will hear, LDH. It's a blob that basically tells you how much of a tumor most likely you have in your body. And then we appreciate the fact that this is what we call, really you are in a good health status, you have no other medical problem, but you have a really big melanoma, your melanoma is in the brain, that most of us would choose to go with a combination of nivolumab and ipilimumab, what we call Yervoy combination. And some is acceptable if you have a concern about, that your disease is, side effects may be like compromising your life and etc. And this is a very, a long discussion with the patient. So if we see that really we don't have any of those high risk factors and everything is good, and so I would clearly be open to choose nivolumab and relatlimab, which is the Abdullah combination. And I have to tell you that we here at United States are very fortunate to have this combination approved, and we use this often. We as a physician, as I highlight here in very, very light, we should really ask ourselves a question why we have to choose this single agent as opposed to this combination. And this can be an answer. And for example, if someone has some serious comorbidities or has something which is called autoimmune disease, which already boosts your immune system, and we are very concerned about side effects. So in some circumstances, we can definitely use these single agents. And obviously for patients who are not eligible, or if they tried the immunotherapy and it did not work, or some for other reason, we can use the pills, BRAF, for patients who have a BRAF mutation. And I would like to conclude that obviously clinical trials are available. They are available to start like from frontline when you did not receive any therapy. We encourage always patients to participate. We discuss with them all of these standards. We encourage them because whatever is a clinical trial today, whatever is standard today was a clinical trial years ago. But I always like to highlight as well that anti-cancer drugs are not always the right choice of treatment. And if you have some comorbidities or there is something more that these drugs may help, may even harm, only supportive care may be also reasonable. So this is all I have. Thank you.
All right, and our last official presentation is from Dr. Vernon Sondak. He's going to talk about another approach, an investigative approach that we are pioneering here at Moffitt, adoptive cellular therapy or tumor infiltrating lymphocytes for melanoma.
Thank you for the introduction. I know that other speakers have covered all of these wonderful agents we have for treating melanoma. And this slide really represents the timeline, sort of answering the question about what came first in terms of melanoma treatment. And in 1975, really what we had available for advanced melanoma, not curable with surgery due to spread, was chemotherapy, dacarbazine, or DTIC. And there was a long period of a few decades before we got approval of interleukin-2, which I'll be talking about. It's a cytokine or a nutrient that boosts the immune system, kind of similar to interferon. Interferon was approved for stage 3 melanoma. These drugs are all for mainly stage 4 melanoma, at least for the regulatory approval timeline. And then there still was a period of a little bit more than a decade. Then we got a series of rapid approvals of all of these different agents. And like I said, they've been discussed by the other speakers. But the one thing I do want to add with regards to these agents is they all share a common feature in that they boost immune function. Even the targeted inhibitor therapies, while they are thought to directly inhibit tumor growth by the drug interacting with the tumor, even targeted inhibitor therapy interacts with the patient's immune system and boosts an immune response. So the bottom line on this slide is that these drugs all work on the immune system, specifically the T cells or the T lymphocytes I'll be describing. Moffitt did lead an international multi-center trial that will hopefully add T cells or TIL, tumor-infiltrating lymphocytes, to this list of approved drugs, and that's going to be the focus of my talk. Well, just to start off as an introduction, what exactly are T cells and what exactly are tumor-infiltrating lymphocytes or TIL? Well, T cells are types of immune cells called lymphocytes, and there are two different classes of lymphocytes. There are the B cells that make antibodies. These are the antibodies that we hope vaccines like the COVID vaccine will boost. And then there also are T cells. T cells have multiple different functions. T cells can directly kill undesirable cells. That includes cells infected with virus or cancer cells. The T cells that directly kill undesirable cells are called cytotoxic T cells. And there are also other types of T cells, helper T cells, that coordinate the function of other components of the immune system. These helper T cells are what get infected and killed by HIV, causing the disease AIDS. So T cells have multiple functions, and one of those functions that have been discovered are TIL, or tumor infiltrating lymphocytes. These are activated T cells that have migrated to the tumor and possess the ability to kill tumor cells. And this cartoon schematic demonstrates healthy cells, and due to mutations that you've heard of, can cause these healthy cells to transform into tumor cells. These tumor cells display antigens or proteins that are different from the healthy cells that are actually targeted by these TIL, or T cells, that infiltrate the tumor and kill the tumor. And this is a natural phenomenon that's known for many, many decades, that when you cut tumors out of patients, you can find T cells within the tumor, but in the tumor inside the patient, the tumor cells develop ways of avoiding the TIL being able to destroy the tumor. But we've, and among others, have come up with a way of culturing these TIL, expanding them and using them as a treatment. So why are TIL important? Well, it turns out that melanoma has a lot more mutations than other types of cancer. So the mutational burden of melanoma is relatively high. These mutations are changes in the DNA that causes changes in the protein of the tumor that create targets for the immune system, including the TIL, that can recognize these mutations as not supposed to be there and eliminating them like they're a virally infected cell. The higher degree of TIL infiltration in tumors like melanoma is associated with improved survival of patients. So some patients have melanomas with lots of TIL in there, and there are some patients that have very sparse TIL in there, and the patients who have high TIL infiltration have better survival than patients with low TIL cell infiltration. And just as a conclusion of this slide, response to immunotherapy for metastatic melanoma is associated with a T cell infiltrate. So some of these drugs that have been discussed by others, this immunotherapy can cause infiltration of the tumor with the T cell, and patients who have more T cell infiltrates do better. So this natural phenomenon of discovering TIL in tumor was taken advantage of. Originating at the National Cancer Institute, surgeons like us at the National Cancer Institute removed tumors from patients and discovered that one can culture these TIL from the tumor. The tumor is typically removed in the operating room, and taking the tumor out of the patient and explanting those tumors in the lab can result in the investigators manipulating the lab conditions that favor the growth of the TIL in the lab over the growth of the tumor. In order for the treatment for these TIL to be given back to the patients, it does require a preparative chemotherapy that temporarily depletes the normal immune cells in the patient, so that when the TIL are given, they don't have to compete against the normal immune cells. And then after the T cells are given to the patients do get a short course of something called interleukin-2, which is a nutrient or a cytokine that boosts the growth of the TIL in the patient. These TIL have multiple different targets, and that's called polyclonal. And one of the benefits of TIL is one does not have to discover the targets of therapy. It naturally occurs and can be exploited. So unlike targeted inhibitor therapy that Dr. Karapetian discussed, those tumors have to have a mutation in the BRAF gene. In the case of TIL, the targets of therapy do not require to be defined ahead of time. This is a cartoon schematic of how TIL therapy works. A patient presents to the office with metastatic melanoma, unresectable disease, so can't be cured with surgery. A portion of the tumor is removed in the operating room. The cartoon schematic of this tumor shown here with the irregular brown large cells being the tumor cells, and infiltrated within these tumors are the small round cells that are different clones of T cells or TIL. The tumor is plated in the lab and cultured with the same interleukin-2 that I talked about. It's a growth factor for the T lymphocytes or the TIL. The TIL are grown to very large numbers. They can be selected for, so the properties of these TIL can be explored and can be selected for in terms of the TIL that are good, meaning that they can recognize and reject the tumor, can be tested for. Those subclones can then be pooled, expanded to tens of billions in number, and then given back to the patient. But before the treatment can be given, the patients get a lymphodepleting chemotherapy. This is the nuts and bolts of how TIL therapy works. I just want to spend a little bit of time, a word about the lymphodepleting chemotherapy. This chemotherapy is cyclophosphamide and fludarabine. We know for sure that in its present state, TIL do require this abbreviated course of chemotherapy, but we're still not sure exactly why it's needed. There have been some proposed reasons for why it's needed. The chemotherapy may deplete some of the immunoinhibitory cell populations. A leading theory is that depleting the endogenous or the circulating immune cells, the TIL do not have to compete against these immune cells for these substances called cytokines, which are growth factors or nutrition for the T cells. So depleting these circulating immune cells allow the TIL access to these cytokines because it depletes the cytokine sink of the normal immune cells. Additionally, the chemotherapy may actually disrupt some of our normal immunity that causes some enhanced signaling that again results in cytokines that feed the TIL. But what we do know, it's been attempted to actually boost the degree of lymphodepletion, and that has not been shown to be helpful in terms of a treatment effect, but does increase the side effects of the treatment. So we stick with the cyclophosphamide and fludarabine without any other additional lymphodepletion. Well, this treatment is not for everyone just because it's hard on the body. And I think one of the reasons why it's so hard on the body is because of this requirement of the chemotherapy. So we typically do not treat patients above the age of 75 unless a patient has exceptional clinical status, performance status. Even those who are under 75, they have to have the reserve to tolerate the side effects of the treatment. They have to be able to tolerate the side effects of the lymphodepletion, as well as the side effects of the interleukin-2 that's given immediately after the TIL treatment. This typically does require heart and lung function evaluation, and they have to pass certain parameters. Because of the lymphodepletion that drops the platelet count can cause bleeding in the brain if the patient has active brain metastasis, so they have to have treatment with radiation of any brain metastasis before the lymphodepletion. But treated brain metastases are allowed. And then the patients also have a tumor that's reasonably acceptable for side effects of the surgery. In the interest of time, I'm going to skip the next slide and go straight to the outcomes. Well, the originators of this treatment were at the National Cancer Institute in Bethesda, Maryland, and they published their data in 2011. And this is a Kaplan-Meier curve. It's a survival curve you've seen from the other presenters, where the y-axis is overall survival, how well the patients did, and the x-axis represents time. So at time point 0, 100% of the patients are alive. Over time, patients do develop disease progression. However, after about 3 years, you can see a bit of an inflection point where the curve starts plateauing or flattening out, meaning that if patients make it beyond a certain period of time, they can go on to live almost 8 years or beyond in this particular data set. The curve plateaus is about 25%. And in this particular study of patients, there were 93 patients at a median follow-up of 62 months. But I think the take-home message is that over time, once you get beyond a certain point, there's a nice plateauing of the curve at around 25 to 30%. And this is something that you see commonly with immunotherapy, that patients who make it beyond a certain period of time tend to have an immune response that lasts for a really, really, really long time. This slide shows the data from patients that were treated at Moffitt Cancer Center here. The curve on the left, another overall survival curve, and then on the right is progression-free survival. The curve on the left does have this nice plateau as well. At Moffitt, we didn't start as early as the National Cancer Institute did, so we don't quite have as much follow-up as they did at the National Cancer Institute, but we do see a nice plateau of the curve. Now, these patients in the overall survival curve, some of them were treated with other treatment besides TIL after progression. So the curve on the right really shows you exactly what goes on in terms of patients who did not have the disease getting worse over time. And the patients get a one-time treatment with TIL and then nothing else. And just like the curve that I showed you from the National Cancer Institute, there's a nice plateau of this curve around 30%. So again, the take-home message here is that the patients getting treated with this immunotherapy tend to live a really, really, really long time after they make it beyond a certain point, because the immunotherapy lasts for a long time.
What caused the cliff at like 85 and 72 months?
You're talking about the big drop off here?
No, the right
Oh,
there.
this here, okay, so the question is, this curve looks nice and uniform, then all of a sudden there's a big drop here. So this is because the number of patients that are still evaluable at this point in time is relatively small. So every time the curve drops, it represents some patients who died of disease relative to the number of patients still being followed. So as you go from the curve from left to right, the cliffs become more prominent just because the denominator, the number of patients being followed, is relatively small. So the curve drops about 15 or 20%, probably because one patient out of 5 had died of disease at this point in time. So
Or
they're
if
really
it died of old age,
Or
if they
died of
died
old
of old age.
It's death from anything, right?
Death from any
Same thing would have happened.
right. So the reason why it drops is just because the number of patients that made it to this point is relatively few, unlike at the National Cancer Institute where they had more patients and followed for longer. But you can still see here, there's a relatively big drop compared to these tiny little drops. It's because there aren't that many.
Each vertical mark, go back, is a patient who's still alive at that point. And that's the
It's
last we know. So I actually see there's 1, 2, 3, 4 on that last part of it. So 1 out of 5 dropped out. That's a 20% drop.
Makes
And
sense?
Yes, thank you.
Good question. So I also want to show you some examples, clinical examples of patients, and of course, I'm showing you the good examples, but these are quite remarkable. It's a CAT scan, so I'll walk you through it. On the left is before any treatment. This patient has a relatively large tumor in a place that's very difficult to get to surgically and also very challenging to treat with other measures like, for example, radiation, because the tumor is adjacent to the liver and the pancreas and the stomach. And in fact, we actually operated on this patient because the tumor had actually eroded through the stomach. So we actually did try to remove this tumor and found that it was actually invading into the body of the pancreas, so we couldn't get all of it out. The patient presented with a GI bleed. The tumor eroded into the stomach, causing bleeding that ended up bleeding through the stools. And we removed as much as we could, and we solved the problem of the bleeding, but the tumor actually grew back to the extent that it was almost like we didn't do surgery on them at all. The patient did have another tumor that was more easily removable from the side. So we took that tumor out, grew the TIL, treated the patient, and then 5 years later, there was a complete radiographic response. And this patient is now 12 or 13 years out without any signs of a recurrence. So this is an example of a patient with a bleeding tumor that we tried to get out surgically, couldn't do it, but then treated with TIL, and that solved the problem. This next is a photograph of a patient who had a very painful tumor adjacent to the elbow at baseline. We harvested a different tumor from somewhere else, and the patient was treated with TIL. They're still in their hospital gown recovering from the cell therapy 8 days later, and the tumor got a little bit hot and then quickly melted away. So this is an example of a rapid response to TIL therapy. And I wish all patients had this kind of rapid response, and they don't, sorry, but so hopefully you guys keep your breakfast down, but this is the last photograph of a patient with a very large tumor on the bottom of the foot. This patient had so much pain, they couldn't walk, they were in the wheelchair, and it's one of the relatively rare cases where a patient actually asked us to perform an amputation because the tumor hurt so much and interfered with their activities of daily living. They thought they wanted the amputation to get rid of the tumor. But instead, what we did is we harvested a tumor from the groin, treated the patient with TIL, and 3 months later, There was a significant shrinkage. And then 3 years later, although we did remove like a small piece of tumor that was just stuck behind, but 3 years later, the tumor is completely gone. So this is an example of a clinical response of a large bulky tumor to TIL therapy. And this is the patient that was actually featured on an NBC Nightly News, although they did not show that photograph for obvious reasons. So I want to talk a little bit about side effects. Dr. Karapetian had mentioned side effects of immunotherapy with nivolumab and the like. These are the side effects of TIL therapy that we've seen at Moffitt. And I separate them into two different categories. There's the acute toxicities, which I believe are related to the chemotherapy, the TIL and or the IL-2. And because they're given one after the other, it's hard to tell what's causing what, or whether it's due to all of the above. If the patients do develop relatively high fevers, they can get up to like 104 degrees Fahrenheit. These fevers are accompanied with relatively severe flu-like symptoms, shaking, chills, feeling run down. This is probably related to the TIL making these cytokines or these substances that boost the immune system. And we're also giving them extra IL-2, interleukin-2 can also cause these symptoms. The patients do develop pronounced shaking, chills, or rigors. I did treat one patient who was a weightlifter, and he would shake the bed so hard you could hear the banging. I thought that someone was angry patient pounding on the door, but it turned out to be the shaking rigors of the bed hitting the wall. Patients do get low blood pressure, low oxygen levels. They can get organ system dysfunction like kidney and liver failure. But fortunately, these symptoms resolve pretty quickly inside of a week and usually require common sense supportive measures. Patients get better on their own when the effects of the chemotherapy wear off and the immune system from the bone marrow recovers. And there are relatively few new treatment-related adverse events after the 3-month time period after treatment, mainly because if the treatment works, the patients do not require any other treatment. It's not like you're giving multiple cycles of drugs. I'm sorry. However, there are some chronic or long-term side effects, which I believe are mainly related to the chemotherapy. So if there's a way to get rid of the chemotherapy, that will do a lot of good. But rarely patients can get side effects probably from the TIL. The TIL are supposed to reject the cancer, but some of the normal cells of the body share these same targets that the tumor has. So I call it an on-target off-tumor effect. The TIL may attack a normal cell of the body that shares a protein similar to the tumor. On the top of the red line, these are the side effects from the chemotherapy: fatigue, neuropathy. The chemotherapy can infect the bone marrow, causing a problem with bone marrow function. The on-target off-tumor effects, these are the TIL probably attacking cells of the normal body. The inner ear has these hair cells that can get damaged by the TIL. One patient did require hearing aid and had a bit of a disequilibrium because the inner ear affects balance. Commonly, patients get loss of skin pigmentation called vitiligo. This is probably the melanocytes of the skin that cause skin color can get eliminated or reduced by the TIL and cause patches of white or vitiligo. And then we heard about uveitis from targeted inhibitor therapy. You can also get uveitis or inflammation of the inner eye from the TIL. I want to talk about a couple of other clinical trials that are important. Again, this is a Kaplan-Meier curve of progression-free survival over time. And again, you can see a very nice flattening of the curve. Again, 20-30% long-term survival. This was a randomized trial that compared the blue line was TIL and the red line was ipilimumab, which trial was conducted in Europe, where ipilimumab is occasionally used as the first or second line of treatment. The TIL arm was significantly better, like Dr. Karapetian said, the higher the curve, the better. And I want to reiterate that there's a nice plateau of the curve, and even though these are all different trials, it all results in the same type of, after a couple of years, there's a nice flattening of the curve. And then, we'll skip over this. The next clinical trial I want to talk about is using TIL to salvage patients after progression on nivolumab or pembrolizumab. So the efficacy of TIL in PD-1 treatment refractory cases. This was a multi-center trial that Moffitt was the lead center in. And this trial is actually under consideration for FDA approval. The important point to be made here is that just like Dr. Karapetian said, if you give one line of a type of immunotherapy and then try to do a second line, the responses are a lot worse, probably because you're using a similar class of drug. And if it didn't work the first time, it's not likely to work as well the second time. So every time there's a treatment, line of treatment, patients tend to do worse. However, with TIL, while it is a form of immunotherapy, it probably has a slightly different way of working, a different mechanism of action. And just like how I showed you about the curve plateauing at around 25 or 30%, this trial looked at response rate in the patients who did not have effectiveness with the nivolumab or the pembrolizumab, and we found a 36% response rate in this trial. And some of these responses were long-lasting, is that median or the average duration of response was not reached at a follow-up of more than a year and a half. And then this is the survival curve of this trial. It was a single-arm trial, so there wasn't a comparator arm. But you can see that after a year and a half, there's a nice flattening of the curve. And again, you're kind of in that same ballpark range of around a little bit higher than 30%, but we still need more follow-up on this trial. But I think you're going to see a eventual plateauing of the curve around 30% as well. So this indicates that you take the patients, whether they've had PD-1 antibody or not, the response rates end up being similar. And that means that while the treatment is complex and does have some side effects, this treatment can be used for patients where the PD-1 antibody didn't work as well as what we would have liked. A little bit about the future of TIL therapy. More work is being done in order to try to improve the treatment, and there are a couple different ways to improve the treatment. You can improve the effectiveness, make the response rates higher, and Moffitt is integrally involved in these efforts. We're trying to select the TIL, so if these tens of billions of TIL, maybe only a small subset of these TIL actually do what we want, and the rest either contribute to side effects or crowd out the TIL that you want. So we're selecting the TIL for better responses. Another company is actually knocking out the PD-1 gene in the TIL to make the TIL more active, and we're attempting to open this trial here. And then there's also efforts a little bit further down the road of maybe combination therapy, TIL plus intralesional therapy is under development at Moffitt. Not yet ready for prime time, but we're working on it. We can also enhance patient access to the treatment. So it takes about 6 to 8 weeks to grow the TIL in some cases, but there might be ways of accelerating the growth of the TIL, and that process actually has been patented by Moffitt and being explored for clinical use. We can recover TIL from core needle biopsies instead of a surgical excision so that more patients can get the treatment without having a really big surgery, and that process is also being patented by Moffitt. And then there are other places that are looking to select and expand these T cells. Instead of going for TIL, you can maybe extract them from the peripheral blood. And then there are probably future efforts to reduce side effects, perhaps by eliminating chemotherapy, which is one of my pet desires, or eliminating IL-2 proposed by others. So just to wrap things up, TIL cellular therapy is relatively complex, but it is feasible as reported by single institutions like Moffitt and National Cancer Institute, and in a multi-center trial that Moffitt was the lead center on with centralized manufacturing. TIL therapy for metastatic melanoma has extended progression-free survival compared to conventional immunotherapy, ipilimumab. That was that study done in Europe. TIL therapy is effective in salvaging patients with metastatic melanoma refractory to multiple lines of prior PD-1 antibody or immune checkpoint blockade. And then ongoing research is testing enhancing function, enhancing patient access, and reducing side effects. And thank you for your attention.
All right,
Okay.
I'm going to turn it over to you for a few minutes.
Okay. We are awash with questions. Here you go. And I know you have more, and our two volunteers are writing as fast as they possibly can. I beg 5 minutes of your time to talk about, I'm back to talk about AIM at Melanoma and how we want to support you during your journey. So let's see. Uh-oh. How do I get it to go to my slides?
That I do not know.
Different presentation
Oh,
file.
the different presentation? We didn't know you had a presentation.
Oh, I'm sorry, yes, I have some slides.
There you go.
There I am. Okay, all righty. So, AIM at Melanoma is going to support you through your journey. And what we have done is build a website that is a soup to nuts site for you to visit. And it's there for you for basically for 4 reasons. First is, do you need general information? Are you early on your journey? Do you need information on Melanoma 101? We have melanoma videos, we have web pages that talk about things like, side effect management, staging, those kinds of things. And we also have a clinical trials matching service. So please come and visit our website. It has lots of information which is intentionally relevant, up to date, and accurate. Do you have clinical questions? Are there questions that are still in your mind from your last visit to the doctor? Well, we have a program called Talk to a Medical Expert. Melissa Wilson is a PA who works at the Hillman Cancer Clinic. And she will answer your question. She is not going to alter your plan of care, but what she will do is help you with clarifying questions. Like people will write to us and ask, they need help understanding their pathology report or a test result. They need an explanation of their treatment options, or maybe they want to understand how to manage their side effects. So Melissa we have a form online. You can go in, fill that out. She will write back to you and answer your questions. Are you looking for additional educational opportunities like today's symposium? AIM sponsors 10 symposiums a year. After the symposium is over, like this one, we will take these presentations, divide them by topic, and they will go back on the webpage that you registered for the symposium. And that takes about 2 weeks, and you'll get a link that tells you that they're back on there, because we know that there will be some of today's presentations that you'll want to see again. But you also we have a video library, and you're welcome to go and look at presentations from past symposiums as well. We also have a webinar that's called From the Clinic to the Living Room. And back to Melissa Wilson, she is the host for that webinar series. What she does is she takes the questions that are most frequently asked of her in our Talk to a Medical Expert program, and then she fleshes those out into about 20 or 30-minute long webinars. They're absolutely excellent, and I suggest that you check those out. And lastly, we have a podcast called Beyond the Clinic. And it is hosted by Dr. Raymond Liu. He is an oncologist with Kaiser Permanente. And what those podcasts are for are topics that are not typically, I'm not saying they're not ever spoken to or talked about during your visits with your physicians, but they're not typically talked about in clinical settings. So the kinds of things that we've talked about there in the last 6 months are functional nutrition, the value of exercise, sun safety, dealing with anxiety, and also Dr. Sondak was on in December talking about the future of cancer treatment. So please check those out. They're absolutely fabulous. And the last reason that people will reach out to us is because they want to connect. They want to connect with AIM. They want to connect with each other. And I want to tell you about a program I think is very important that we have through AIM, and that is our Peer Connect program. What we do is we do one-on-one matching. So we take someone who has completed their treatment journey and pair them with someone who's at the beginning of the treatment journey. And this is an opportunity for our mentor, we call them mentors, for them to offer insights and empathy and walk this person through their journey. And so if you have an interest in being a mentor, this is my moment to ask you to consider to do that. We specifically need mentors and caregiver mentors as well. And then if you're someone who's starting their melanoma journey and you'd like someone to walk alongside of you, somebody to invite into your circle of trust, then reach out to me and I will connect you to a mentor. And then the other reason that people want to connect with AIM is because they want to help us to continue our work. They want us to help us spread awareness. And I have a friend here with me who wants to come forward. Her name is Mary Margaret Raddick, and she is a Moffitt patient. She is the organizer of a local walk that we have here in the Tampa area, and I'm going to let her tell you about herself and about that walk.
Yes, and I am so lucky to be here, kind of twofold. First of all, as a patient of the Moffitt Cancer Center, and feel very fortunate to live in the Tampa area and to be able to seamlessly be treated at Moffitt. And I had the opportunity to participate in a clinical trial here. This past year, I was initially diagnosed with melanoma at the age of 40. I was stage 1B I had a mole taken off the back of my leg, and then I had the wide excision surgery. I did not qualify for the sentinel lymph node biopsy because I was under the 0.80, I was 0.68 in illustration. So I went on, had skin checks every 3 months here at Moffitt, and 5 years went by, nothing. And then last January, and I'm gonna share this bit of information because it's what I really feel like let me catch this super early as far as, not super early, stage 3B, but I felt my lymph node in my groin, my surgery was on the back of my leg, and my lymph node right here, I felt it swollen and it felt like a marble. And my dermatologist had told me, if you ever feel a lymph node that feels like a marble, you need to call right away. And that I did that, and they were like, you're symptomatic, came in, got biopsied that day, and met with the oncologist, Dr. Kushalani, who is incredible, and I am just very, very thankful to be one of his patients. I got into a clinical trial, and I did echo Benny, which is BRAF MEK. I was BRAF positive, and did 5 months of treatment, neoadjunct, and then I had my surgery with Dr. Sondak. And I am currently no evidence of disease, and very thankful for from 1B to 3B after 6 years, which is rare, but again, very thankful to have the opportunity. And when I got diagnosed with the 3B, I didn't know. I wanted to just research everything and read everything and find a community, because I felt kind of isolated as far as people who I'd known. I didn't know anybody who had gone through treatment for an advanced stage melanoma. So I came across the AIM website, and I did the peer-to-peer connect, and read everything I could as far as educating myself on resources, and pretty much read the whole website and decided that for me, it was really important to give back, to raise awareness for melanoma, and then also to provide funding as much as I could for clinical research. So that is what my purpose has become. And I work in a volunteer position with coordinating the walk here in Tampa. And I would encourage all of you to sign up and participate. It will be on April 16th. It's a Sunday at Al Lopez Park. And Moffitt is one of our sponsors, and they are providing the mole patrol, and they also have volunteers there helping coordinate the event. And if you just go to the website, the AIM website, you can register for the event here in Tampa. And I know that there are walks throughout the country as well that people have called into the symposium. All of them are listed online and should be active. And so yeah, please come out and support us. We'd love to have a bigger community here in Tampa, even for just mentoring and networking and feedback. So go online and sign up. We'd love to see you there. I will be there in my black shirt.
More information on our website, more information about the walk. Here is my contact information. We've also put it in the chat. And with that, it's time for questions and answers.
Yes, all right, we're gonna have one great question here. I'm gonna ask each of our three panelists to answer. What do you consider the most important research or most important changes that in treatment that you see we're gonna have in the coming year? We'll start with you.
I'm biased, but I'm gonna have to go with TIL cell therapy. I think one of the things I didn't have time to mention is that taking the tumor out of the patient allows us to manipulate the immune cells in a much more profound way than what treatment can be given internally to the patient. And I think we're gonna see a lot of fruitful research to boost not only responses, but to actually learn about the field of immunology. I think there are some aspects of our knowledge, like anatomy, that's pretty much done deal. You can read in the textbook, but immunology is the future.
All right.
Not necessarily in the next year, but in the near future, I think we're gonna see combination immunotherapy becoming the standard of care in the neoadjuvant setting of melanoma.
It's all about immunotherapy in melanoma, but something that may be really important in short term to approve that combination therapy actually specifically for WAC may be beneficial over single therapy in the adjuvant setting, because we still continue to see a lot of patients who already have their surgery. And it is important to have drugs that may prevent future recurrence.
Great. And I certainly think that the ability to use the treatments before surgery, I think what we're going to see is increasingly people needing less surgery. For example, just yesterday, we removed only one lymph node in a patient who previously would have had to have his whole, all the axillary lymph nodes removed. You said 6 years, his original melanoma was from 1997. And he developed a lymph node under the armpit, so there's still a huge amount we don't know about melanoma and why it would take so long to come back. But with just 2 doses of Ipi-Nivo, it shrunk away. We had marked that lymph node ahead of time. We could just take that one out. If that one is really negative, he probably won't need any more treatment at all. Instead of a year of treatment, instead of all the lymph nodes, we'll be on the verge of just a few weeks of treatment and a much smaller surgery. What about vaccines, either to prevent melanoma or treat it, and particularly the technology that was suddenly mobilized to create COVID vaccines, can that be used to eventually treat or prevent melanoma?
Yeah, sure. I mean, there is significant advances in the vaccine technology in treating cancer, and more specifically in melanoma. In the past, we used to make vaccines that target melanoma antigens that are also shared with the normal tissue, like the pigment cells, the melanocytes. Now the technology is we go after the tumor itself, we do this genetic sequencing, and we look for those so-called foreign antigens or so-called mutated antigens that the cancer comes up with because of the mutation of the cancer. Now you can develop a so-called personalized vaccine or a targeted vaccine that goes specific for this cancer. And there is recent, very encouraging data from a study led by a company called Moderna. There is a lot of plans for this to be developed further in the future. We were part in a study as well that was recently concluded, and the results will be shared. But yes, vaccine technology, I think approaches will become part of the standard of care, in my opinion. The advantage of those as well, the fact that they're being targeted, they have less side effects, than the other treatments that we see. So I think that's the promise.
All right, we talked a lot about immunotherapy. Got a few questions about targeted therapy that I think are really good. And I'll ask them all to Lily and have you kind of combine them all. To be a candidate for targeted therapy, do you have to have a mutation? Is the mutation inherited, or is it just in the tumor? And what if it's not a BRAF mutation? What if it's some other kind of mutation like c-KIT? And are there other mutations that we could target?
So BRAF status is always important. That is the number one that we always check. And this is a mutation change that is in your tumor. This is not an inherited genetic mutation, this is in your tumor. And even if you look at the BRAF, there are specific different types of BRAF mutations. And the one that is what we call is approved by FDA, that we know it works for targeted therapy, is something we call V600E or V600K. So you may have some other BRAF mutations in your tumor that you may read, but your physician may say this is not type of a tumor, that type of a mutation that we use to use the targeted therapy. Now, that is the first step that we always do. But behind that, there are some other pills that are in the scope of clinical trials that we have at Moffitt. Here is why when patients come here, they may have often only BRAF tested as a V600E, okay? We do extended analysis that colleagues mentioned, such as Moffitt Star, which provides us information about other mutations, including other types of BRAF mutations, as well as something which is called NRAS mutation, that we have a clinical trial that we can incorporate some pills for those type of mutations. And there is some types of melanomas which are mucosal melanomas, which happen not in the skin but inside, like a head and neck sinuses or in the gut part, or these can have a c-KIT mutation. While we still prefer to do the immunotherapy, but if immunotherapy does not work for those patients, we do have a pill that we can use for that type of mutation. So you always look to see all of those listed in your records, and if you do not have, you can request to do further testing.
All right, Ahmad, a few specific questions about TIL therapy. If you had side effects from the immunotherapy, say ipi-nivo, would TIL therapy cause those exact same side effects? Do you need a certain number of the TIL to get success, and how long are you in the hospital? And one other question, if you can cover that too, in a case like the one you showed where the tumor seems to disappear, is the melanoma really gone?
So first question about toxicity. Fortunately, we do not see any overlap between TIL toxicity and toxicity from a previous line of therapy. That's good news, and I think it reflects the fact that TIL have a different way of working compared to these other treatments. However, toxicity from a prior line of treatment may make you ineligible for TIL. In particular, a lot of the immunotherapy can affect the pituitary. The pituitary is an important endocrine gland that results in our stress response. It results in cortisol response. So when you're under stress, you need your pituitary to signal the adrenal gland to push out more steroid, and that can be a problem if you don't have that function and you get the TIL, because your body won't respond like it should, so that would make it dangerous. Second question was, what again?
There was a question about the amount of TIL you needed and how long you'd be in the hospital.
So number of TIL needed, it kind of varies based on reports. At Moffitt, we think that for it to be successful, you need at least 30 billion. However, we're working on ways of selecting out of those 30 billion the ones that work the best, and then we're hoping to be able to get by with far fewer TIL. Other studies, like the multi-center trial that I showed you, did not have a relation to TIL number and response. So they did see responses at low numbers. So the jury is still out with regards to how many TIL you actually really need. We don't really know for sure.
And the length of time in the hospital?
Usually it's 8 to 10 days, and it's mainly for the lingering effects of the chemotherapy to go away. So if there's a way to get rid of the chemotherapy, that'll solve a lot of that problem. But right now, in its present form, it's usually an 8 to 10 day hospitalization.
Okay, and once the tumor disappears, is it really gone?
So you notice, and the question was raised about like that big cliff at the end of the survival curve. We hope that it's gone. I think the person who kind of discovered and implemented TIL, Dr. Rosenberg at the National Cancer Institute, he will tell you that when it's successful, TIL will eliminate each and every tumor cell from the body. However, it's not a guarantee. Unfortunately, we do see some patients who progress 5-10 years out, very similar to what Dr. Sondak said. He had a patient in 1997 who had surgery. Obviously, there was maybe one cell left behind that eventually grew over those 30 years, and something like that can possibly happen with TIL, but we do have people who are now more than 20 years out without a recurrence, and I'm hoping that most, if not all, of those patients are cured.
Okay, here's a great question, because we didn't really cover this at all. This focus was almost entirely on skin melanoma, but Ahmad, how is uveal melanoma different, and what's the best treatment today for metastatic uveal melanoma?
So uveal melanoma starts in the pigment cells in the back of the eye, so-called the choroid and other pigmented cells inside the eye. So it's different, completely different from skin melanoma in terms of its responsiveness to treatment. When it spreads, it tends to spread to the liver in about 90% of patients. It may go to the lungs, it may go to the bones as well. It's challenging to treat, unfortunately, being a relatively uncommon disease. There has been, less advances, let's say, and less, major investment in major studies in uveal melanoma. Recently, a study called, an agent called tabentafusp, which is a form of immunotherapy, was approved by the FDA to treat patients with uveal melanoma. It's a form of immunotherapy that acts as a fusion protein, that in a way it is specific to an antigen or a protein on the melanoma cell, and also links to a T cell, which is the immune system cell, and kind of brings the T cell towards the melanoma cell or uveal melanoma cell. It's a start. It's not we don't see great results. We see improvement in survival, no question, in a major study that compared it to, chemotherapy and PD-1 as monotherapy and Yervoy. But the response rate in terms of seeing major shrinkage was only 9% of that study. So it's a good start, and we're very optimistic. Other data in smaller studies have looked at Opdivo plus Yervoy, so nivolumab, and showed about, somewhere between 15 to 20% responses. The good thing about these responses, when we see them, most of them are durable. So we could expect that most of these patients will go on maybe for years in those who respond. We at Moffitt have now 4 different clinical trials that are specifically targeted towards patients with uveal melanoma or ocular melanoma. We have a lot of investment in doing research and clinical trials for these patients.
All right, well, take a couple of last questions. Maud, why aren't we doing full body PET scans every year, even if the melanoma wasn't in the lymph nodes? And does the radiation from these scans increase the odds of any other type of cancer?
So PET scans have the virtue of having a very high sensitivity. Dr. Tarhini mentioned that the PET scan involves taking a glucose out of the blood, labeling with a radioactive tracer, injecting it back into the veins, letting it circulate. And anything that takes up that glucose releases that radioactivity is detected by a PET scan. The problem with the PET scan, it has a notorious high false abnormal or false positive rate, upwards of 30%. For that reason, we usually get a PET scan before we plan a change in therapy or start of surgery, but it's not quite as good as a screening tool for patients because of the high false positive rate. PET scans are associated with a higher degree of radiation exposure compared to CAT scan, but I really am not aware of any particular study that says that a PET scan could actually cause cancer. This is a problem though for patients with BRCA mutations. There was a study of mammography, which has much lower radiation exposure, can actually cause breast cancer in patients who are BRCA positive. So I suppose it's theoretically possible, but not clinically seen.
Particularly, it is a big concern in pediatric patients. Maybe in young adults. The older we are, the less susceptible we are to low-dose radiation damage, although thyroid cancer is probably a concern. Now, I think we'll make this the last question, at least before we terminate, and we can have some more discussion. But the studies all had a time limit between the surgery and the adjuvant therapy. It might be 56 days, might be 78 or 80 days. Is there a loss of the effect of the adjuvant immunotherapy after a certain time? What do you do with a patient where there's a long delay between surgery and considering adjuvant therapy?
So the key is to give it safely and not to cause harm to the patients by starting the adjuvant therapy too soon. And the clinical trials that we have done in the NCI-sponsored cooperative groups, as well as those done through the industry, typically we allow up to 12 weeks between the last surgery and the start of the adjuvant treatment. In one study, we allowed 14 weeks, and that's considered part of the standard of care. So if we go 12 weeks up to 14 weeks, that patient would have been able to go on a study. And one of those studies that was eventually positive in terms of adjuvant therapy. So that's not a concern as long as the patient is cleared from a surgical perspective, they're well healed, they're safe to start treatment, that potentially can be toxic and cause side effects. So the delay sometimes is in the best interest of the patient.
So just to add further, I think that's another advantage of doing upfront or neoadjuvant therapy is that the patient is pretty much guaranteed to get the systemic therapy, whereas if you push the systemic therapy to after recovery from surgery, if there's some problem from the surgery or other logistics that delays the adjuvant therapy, there's a chance the patient may not qualify for any therapy at all. And I think that's an advantage of doing the upfront therapy, one of the.
I agree. That obviously applies to those patients who have the bulky disease
Yeah.
and, are candidates for the neoadjuvant therapy. I have to say that we are starting to do upfront treatment for patients with early disease, but it's still very experimental, small studies. We'll see what the data shows.
Okay, Dr. Sondak had to run out for a minute. This is the end of today's symposium. He wanted to, he asked me to offer to you the opportunity to stay around and talk with him, visit with him personally before you go. But for those of you who are online, we want to tell you that if your question did not get answered today during the symposium, you are welcome to go to the Talk to a Medical Expert web form and fill that out for Melissa, and we'll do our very best to get an answer to you. And with that, I'll say thank you to everyone who has joined us virtually, and thank you to everyone who came today.
Thank you.